A very good evening to all of you present on today's session. I am Nishita from ClearNet. Welcome all of you on Indian Menopause Society IMS President's Webinar Series 1 in association with Jaipur Menopause Society. ClearNet is proud to be associated as a digital partner. Now, I am going to play a very short ClearNet's video. I would like to request all of you, please have a look. Thank you so much everyone for your patience watching. ClearNet is India's largest live digital CME and doctors generated medical content platform. Now I would like to hand over the session to Dr. Shubha Shethia ma'am. Ma'am is the president of JMS. Ma'am, over to you. Please proceed.
Thank you, Prachi. Good afternoon, everyone. I, Dr. Shubha Sethia, President, Jaipur Menopause Society, along with Dr. Shobna Mohandas, President, Indian Menopause Society, Dr. Anju Soni, Secretary General, Indian Menopause Society, and Dr. Madhulika Agarwal, Secretary, Jaipur Menopause Society, welcome you all to today's session on aging gracefully. Aging gracefully is not just how to defy age and look young or smarter. Aging gracefully means what we want to do, what are our desires, and can we, aging will come, death will come, but can we use the time in between to fulfill all our needs and desires? Can we be physically, mentally, psychologically, emotionally, as well as financially happy and content? So this is what is aging gracefully. And today we are very lucky to have our chief guest, Dr. Shobna Mohandas, President, Indian Menopause Society, who, Madhulika, can we see the CV? Hello. Hello, please, am I audible?
I am sharing just now my screen.
Ma'am Shobna Mohandas needs no introduction, and we are very lucky to have her as President, Indian Menopause Society. And her vision for this women in midlife and care of women in midlife is what we have heard in her presidential address too. She has started this series of Pearls of Wisdom in order to disseminate knowledge about menopause amongst us, all the medical fraternity, so that we are able to take care of women in menopause to our utmost. Apart from that, her vision has always been not only to look towards the women in midlife and menopause, but also lend a helping hand to women in old age homes who are not able to take care of that. And she has motivated all of us to do the same. And similarly, her dedication towards research is also great. And she is motivating us always for this. I would now request Madam Shobna Mohandas to give a few words of wisdom to all of us.
Dr. Shobna, you're muted. Dr. Shobna, you're muted. Dr. Shobna, you're muted.
Shobna ma'am,
unmute yourself and talk. Shobna, she's somewhere.
I just saw her. She's muted, I can see.
Yes, she is muted. I'll just ring her up and inform her.
Not only muted,
Ma'am,
she's
I
not
have
able to hear us also.
Dr. Mohandas, I have request you to unmute. Can you please unmute? I have sent you the request.
ये भी दिखे और वो भी दिखे.
Can you unmute her, Prachi?
Ma'am, I cannot unmute her. I am also sending the unmute request. She needs to unmute.
Okay.
Dr. Mohandas, I'm sending you the request to unmute. Can you please unmute yourself?
Ma'am, please unmute yourself. You are not audible.
Hello, Shobna ma'am.
Yeah. You
Shobna
are
ma'am, you have
unmuted.
to unmute yourself. Hello.
Then Nikita has already sent you a request.
Hello.
Hello,
Yes,
Shobna ma'am.
you are audible
Yeah.
now.
Yeah. Good evening, ladies and gentlemen. This is the third of the series of the webinars which I have been organizing. We have already finished one, and two we have finished, and this is the third one. And Anju has taken over everything, so I'm just not practically involved in it at all. And we will all learn how to age gracefully in this, and I'm keenly waiting to listen to how diabetes can be managed in the perimenopause and menopause, because many of us are diabetic and we are not updated in the current events. And plus, when we have cholesterol, we just need to ignore it, but we cannot ignore it, and we have to really learn medicine before we can do all these things. I hope all of you have a very good webinar today, and I'm waiting to learn from all of you. So good evening and happy webinaring.
Thank you, Shobna ma'am. You are behind all of us in organizing these, and we are really grateful to you for organizing these webinars. I would now welcome Dr. Sunila Khandelwal, a stalwart in menopause medicine. We are really thankful to her to have spared her time for being the chief guest today. Dr. Sunila Khandelwal, as you know, is executive International Menopause Society, founder member, Indian Menopause Society, as well as patron of Jaipur Menopause Society. And we have always seen her as behind our backs, always motivating us. And we would like Dr. Sunila to kindly give a few words of advice to all of us.
Thank you, Shubha, for inviting me and giving me this honor. I'm really pleasantly delighted to share with all my near and dear IMS family members, share my views, and of course, I warmly welcome on behalf of International Menopause Society, Indian Menopause Society, and of course, my own Jaipur Menopause Society, our today's most authoritative, personality, the academician, Dr. Pathak and Dr. Shailesh Loda, who will be enlightening us on the subject, which is very, very important to us, because these two things, they come hand in hand with metabolic syndrome, which is a rising entity. So I'm really happy that these topics are chosen, and I congratulate, of course, Anju and Dr. Shobna for initiating again this series. And to me, I think if I will say about aging gracefully, I'm waiting eagerly to listen others' views. But what I think is that I would like Indian women to come out from the age case and redefine the age. The women should prove that 4 decades till the end of their lives can be most productive if they look after their health, exercise their brain, and lead a whole complete life. So to me, it is aging gracefully is like this. And we know that all the problems are predictable, preventable, and treatable. So I will just go with the slogan of the IMS that we should open the door to all the women in the coming into the second adulthood to help them to age gracefully. And even though the years catch on, let not the beauty and youth fade on. So that's for me, it's the aging gracefully. So thank you so much for inviting me. And I know our galaxy of chairpersons, speakers, and all the panelists, they will make our session very successful. And we will reap the clinical benefits from their knowledgeable points and tips. So thank you so much, and my warm wishes for this successful webinar series to the team IMS 2022. Thank you so much.
Thank you, Sunila, madam, for your great words of advice. And now I would like to invite none other than Dr. Jignesh Shah. Dr. Jignesh Shah is one person who has taught us that how to find an opportunity in diversity. The webinars in Indian Menopause Society are his babies. And we are really grateful to you, sir, for having given us all this opportunity. I would request you to kindly say a few words of advice to all of us. Jignesh, sir.
Thank you, Sobhaji, for the kind introduction and for inviting me as guest of honor to today's webinar. I congratulate Jaipur Menopause Society, especially President Dr. Subha Sethia, then Secretary Dr. Anju Soni, past President and Founder President of Jaipur Menopause Society, Dr. Sunila, and all the stalwarts for Jaipur, from Jaipur, for organizing this webinar. And this is the IMS President webinar series and third webinar of this series. I am here not to say anything, but I am here to listen to the pearl of wisdom from, as this is multidisciplinary webinar from the physician and endocrinologist related with the diabetes, oral anti-diabetics and dyslipidemia, and also a very interesting webinar about the aging gracefully. So I'm sure today's webinar will be very useful to all the gynecologists in their clinical practice, and my best wishes to today's webinar, and thank you again for inviting me. Thank you. Namaskar.
To see you, Dr. Jignesh, after a long time. Thank you.
Namaste.
Shubha, are you there?
Madhulika, you continue.
Now I will like to invite Dr. Anju Soni, Secretary General, to give some words of advice. Dr. Anju Soni.
Good afternoon, everyone, and welcome to Pink City, Jaipur. I have nothing much to say except that today, you know, when we talk of this year's motto, Dr. Shobna Mohandas has taken few things in her hand. One is going strong with learning and covering each and every topic, which is the result of this Pearl of Wisdom webinar series, is her brainchild. And other one is her Dancercise event, which all the members and Club 35 members, they are enjoying, and we are getting very good feedback. And the persistence and is there all through. And third one is her, bill that all of us should go and meet the old age homes, and I think all of us are enjoying that bit very much. Even I had gone to an old age home, and all the societies and chapters are going, and we are, so happy with this new kind of initiative. And third, fourth, but not the least, that her wish to collect this Indian data for Indian women, in which she is talking of hot flashes, and also he has just come up with this self-examination kit, which again will be a data for us, and we'll be able to do some kind of study in that. So I think with all her mottos in mind, I would be there helping her throughout her vision and mission. And of course, with all the advice of all the seniors, all the past presidents, so that we can, make Indian Menopause Society go further, higher up at a pedestal, which all the seniors have imagined. So thank you very much. And let's continue for the education. Madhulika, you muted.
Thank you, Anju Didi, for your pearl of wisdom. Now it's time to start our first session. The session about comorbidities. Nobody grows old merely by living a number of years. We grow old by deserting our ideals. The world population is aging, and an important part of this demographic shift is the development of chronic diseases. Better understanding of how individuals can age healthy without the development of multiple chronic illness should lead to an improved global quality of life. We have all seen how COVID-19 increased the morbidity and mortality associated with comorbidities in elderly patients. Right from first wave, so many elderly people died due to fatal complications. While people are living longer lives almost everywhere, the prevalence of non-communicable diseases and disability increases as population ages. Non-communicable diseases are characterized by slow progression and long duration. Therefore, the clinical manifestation and burden disproportionately affect older adults. The most important chronic disease include ischemic cardiovascular disease, cerebrovascular disease, COPD, diabetes, cancer, and depression. During the 10-year period of premature death from infectious diseases decreased. The proportion of death due to non-communicable diseases rose from 57.1% to 65.5% in a study published in European Respiratory Journal. Years may wrinkle the skin, but to give up enthusiasm wrinkles the soul. So let's hear from our experts about comorbidities in old age. I would like to invite our chairperson. First of all, I would like to invite Dr. Lakshmi Srikhande. Ma'am.
Yeah, Dr. Madhulika, I'm here.
Yes, ma'am. Dr. Lakshmi Srikhande is MBBS, MD, Obs and Gynae, FICOG, FICMU, FIC-MCH. She is Medical Director of Srikhande Fertility Clinic, Nagpur. So many achievements, paper presentations in national and international journals. Welcome, Dr. Lakshmi Srikhande.
Thank you.
Welcome to
The
this
most important thing is
session.
she is chairperson elect for ICOG.
Yeah, Indian
And
College
it's a
of
privilege to have Dr. Lakshmi with us today to chair this very, very important session. And of course, she'll be able to give us her inputs from her side because she's also doing a lot of educational events at her level. So, Dr. Lakshmi Shikande, you are
Welcome,
there
Dr.
for us.
Lakshmi.
Thank you so much.
Thank you, Anju. Thank you.
Next, I would like to invite Dr. Anuradha Khanna. She is MD, FAMS, FICOG, FICS, MNAMS, FUICC, FUWAI, ex-HOD of Obs and Gynae, Banaras Hindu University, Varanasi, ex-President's Box, President Varanasi Menopause Society, and so many involvement in so many societies. And so welcome, Dr. Anuradha, over this forum, and we are privileged to have you with us.
Thank you very much, Dr. Madhulika. I am really honored by us to be here with all the stalwarts and the galaxy and going to listen a very, very important topic of comorbidities, which is the most important things to learn. We all know, but it's much important to listen from the persons who are dealing this comorbidity daily basis. And I'm sure this will be a very successful webinar, and I congratulate Dr. Shobna ji and Dr. Soni ji that they are working very hard And I'm very sorry that for a few months I was unable to be in meetings because of my own problems. So now I will be regular there. Thanks a lot, Dr. Madhulika and your president, for inviting me in this session. Thank you very much.
The pleasure is entirely mine. Now, may I request Dr. Lakshmi to please introduce Dr. Shailesh Loda, a young dynamic endocrinologist from Jaipur.
Thank you, dear Madhulika, for making me a part of this wonderful learning program on metabolic syndrome and aging gracefully. Our chief guest and guest of honor have already highlighted the importance of making our own members aware about the metabolic syndrome in the perimenopause and menopause phase. So it is my pleasure to introduce our young endocrinologist, Dr. Shailesh Lodha, who has done his endocrinology from PGI Chandigarh, and currently he is practicing at Jaipur, and he has also written a very popular book on diabetes in Hindi. So I know, Dr. Shailesh, you are the best person to make us aware about how to tackle with diabetes during this age group. So floor is all yours, Dr. Shailesh.
Madam, I am happy to share that he is also member of our society.
क्या बात है? Very good.
Thank you, Dr. Lakshmi, for these words. And I'll start my presentation.
Lika, you have to stop sharing.
Yes.
Although time of 15 minutes is too short, but just you will get a glimpse of what oral drugs, all the oral drugs which are currently being used. My screen is visible?
Yes.
Okay.
Screen is visible, you are audible.
Okay, madam. Thank you. So these are the names of not of some of your friends or ladies. These are all names of few oral anti-diabetic drugs. Just to give you a brief outline of pathophysiology of type 2 diabetes, few decades ago, this was all what you all have read in your MBBS curriculum, that diabetes occurs because of diminished insulin secretion, diminished peripheral utilization by the muscle, and increased hepatic glucose production or increased hepatic glucose output. So that this hepatic glucose output increases many folds in a diabetic individual, although it occurs normally in every individual. So there were only 3 classic defects which were known to us 2 decades ago. But over the last 2 decades, understanding of pathophysiology of diabetes has increased tremendously. And currently, we believe that there are at least 8 pathophysiological defects in diabetes, and the foremost is impaired insulin secretion. And at the same time, as you know, glucagon is anti-insulin hormone. So there is increased glucagon production by the alpha cells of the pancreas, increased hepatic glucose output. There are some defects at the hypothalamic level also, where there is dopaminergic tone is lowered and sympathetic outflow is increased. Now, the recent concept is now evolving from the gut. It is believed that gut secretes a lot of hormones, and the most important amongst them for diabetes is GLP-1 or glucagon-like peptide 1. This is secreted from the terminal ileum, and it is very essential for normal glucose metabolism. And in diabetic individual, there is a deficiency of GLP-1 also along with insulin. There is increased lipolysis. And what is the role of kidney? That is very interesting, which has evolved in last 1 decade. And now we know that whatever amount of glucose which is filtered by the glomerulus. Large part of it is reabsorbed, which is a normal physiological process, so that we don't waste glucose in urine. But in diabetic individuals, the glucose receptors here are upregulated. SGLT2 receptors are upregulated. As a result, the glucose absorption, which is filtered through the glomerulus, should go out in the urine. Actually, it is reabsorbed again very rapidly. So that is a defect again in diabetic individual. And muscle, we have discussed, there is reduced glucose uptake by the muscle. Now, why it is important to understand these defects? Because the modern anti-diabetic medication is based on this pathophysiological process. So you have insulin secretagogues, which increase the insulin, which enhance the insulin secretion from the beta cells of the pancreas. You have insulin sensitizers, which means that although insulin is not efficient in individuals, but insulin is not acting because of insulin resistance. So these are the drugs which would increase the insulin sensitivity. Same amount of insulin will become effective. And the third group is nutrient load reducers. These are the agents which reduce the glucose absorption or which delay the glucose or carbohydrate absorption from the gut and in the kidneys. The most popular and the oldest anti-diabetic agent is sulfonylurea. And we have currently, all of them are available: glyclazide, glipizide, and glimepiride, which is the most recent and most popular and most safe. Glibenclamide nobody is using these days because of its potential to produce severe hypoglycemia. So it is not at all preferred drug in elderly individuals. A similar class of drug is meglitinide, which is again a secretagogue. Rest of the secretagogues are not actually secretagogues, but they to some extent enhance the insulin secretion indirectly. And these are GLP-1 receptor analogs and DPP-4 inhibitors. And currently, the whole management of diabetes is hovering around this class of anti-diabetic drugs, GLP-1 receptor analogs and DPP-4 inhibitors. Then we come to the sensitizers. You all are aware of metformin, a most potent anti-diabetic drug, very popular, widely used across the world. And actually, it should be used in every diabetic unless there is a contraindication to use. The first drug for first anti-diabetic agent for a diabetic is always a metformin. Then thiazolidinediones, and only pioglitazone is currently available in India from this group. This is a very potent insulin sensitizer, quite safe, but there were several controversies for this molecule, so it is not very popular. Many people, many endocrinologists even, and many physicians, they don't use it, but it is, if it is used judiciously, it is quite effective and very good molecule. These two molecules, amylin analogs, are not available in India, and bromocriptine, although it is available, but now it is an abundant drug. Nobody is using it these days. Another very good anti-diabetic agent is acarbose, which belong to the alpha glucosidase inhibitors. These are the drugs which delay the absorption of carbohydrates in the gut. They are not causing loss of carbohydrate, they are just delaying the absorption. As a result, the postprandial peak, which occurs at 2 hours or 2.5 hours, it is smoothened out. And another very popular drug these days is belong to this agent, this class, SGLT2 inhibitors, which are popularly called as gliflozins. And there are many gliflozins available in India. Currently, these three are widely used: canagliflozin, dapagliflozin, empagliflozin. So thiazolidinedione, sulfonylurea, metformin, and alpha glucosidase inhibitors. These are the molecules which are relatively older, and the newer molecules which have emerged in just last 1 decade and taken over the whole scene is these three molecules. Now, as I told you, each of the pathophysiological defect in diabetes we have to understand when we prescribe anti-diabetic medication to a diabetic individual. For example, if you prescribe SGLT2 inhibitor, you know that the mechanism of action is through the kidneys. So in an individual who has advanced kidney disease, the drug will not be effective because there is no renal tissue left behind for the mechanism of action of the drug itself. Similarly, if you want to start insulin secretagogue, you should know that the diabetic individual should be harboring the disease not from the diabetes should not be very old. Like in an individual with 30 years, 40 years of diabetes, secretagogues will not be effective because by that time insulin is completely exhausted. So insulin secretion, you cannot enhance the insulin secretion in such individuals. Then if there are some gut issues, then you have to avoid the drugs which are acting through GLP-1 mechanism or through the gut. So various drugs act on various pathophysiological pathways, and that is how the glucose is lowered. So how to choose an anti-diabetic drug? These are some of the common factors which are listed on the left side, which we take into account when we prescribe anti-diabetic agent, like age. In elderly individuals, we avoid sulfonylureas because of their potential to produce severe hypoglycemia. Similarly, in octogenarian or even older than that, if somebody is there, then also we avoid SGLT2 inhibitors because of their potential to lower the BP. Or fragile individuals, they may cause sudden drop in blood pressure and people can have falls. Similarly, gender, it is important in ladies who are prone to have recurrent urinary infections or genitourinary mycotic infections. And if there is a history of such infections in the past, we avoid SGLT2 inhibitors. Weight is a very important criteria for choosing anti-diabetic agent. The drugs which are known to reduce weight, like metformin, GLP-1 receptor analogs. So these are the two agents which are preferred for obese diabetic individuals, whereas pioglitazone or weight neutral drugs like SGLT2 inhibitors, they are preferred for individuals who are normal weight or rather underweight. Duration of diabetes, as I told you, for a newly diabetic individual, you can use anything. But as the duration of diabetes increases, we know that the secretion of beta cells is going down. Beta cell exhaustion occurs, and secretagogues have no utility at the fag end of the diabetes after 20 years or 25 or 30 years. But in some individuals, they might work. Generally, we should avoid sulfonylurea in these individuals. Lifestyle, again, that is very important because an individual who is having erratic lifestyle, sleep-wake cycle is disturbed, food timing is not fixed. For these individuals, you need drugs which are non-hypoglycemic. You need drugs which will never produce hypoglycemia. So in these individuals, metformin, DPP4 inhibitors, SGLT2 inhibitors are the preferred agents. Then complications. These days, the whole classification of the guidelines of American.
So your slides are not changing, or is it only one slide on which you are talking?
Yes. We have to take into account the complications. Like if somebody is having renal complications, then SGLT2 inhibitors are the preferred drug. If somebody is having cardiac complications, then again SGLT2 inhibitors are the drug of choice. In advanced hepatic disease, we have to avoid gliptins and sulfonylureas. If somebody is having retinopathy, then again we have to avoid pioglitazone. If there are foot problems, then you have to avoid SGLT2 inhibitors. So this is how you decide how do you choose an anti-diabetic agent. Degree of hyperglycemia is equally important. If somebody is having HbA1c of 10, then you have to start with polytherapy. Generally, to begin with, you may start with just one anti-diabetic agent, but as the disease advances and as the duration of diabetes increases, you have to add one more, then one more. From one, you move to two, then two to three, three to four. So if the degree of hyperglycemia is quite high in the beginning, like HbA1c is 11 at the time of diagnosis, then you will not start with one drug. You may directly start with two or even three drugs. So that is how the degree of hyperglycemia is important. Then there are certain cancers like thyroid cancer or bladder cancer. These are some of the tumors where you should be careful. And if there is a family history of such tumors, or if there is a history of such cancers in the diabetic patient itself, then you have to avoid drugs like GLP receptor analogs. Pancreatitis. If there is a past history of pancreatitis, you have to avoid DPP-4 inhibitors because there are some chances that it might get worse. Inflammatory bowel disease, like again, if the history is there, then you have to avoid acarbose or alpha glucosidase inhibitors or DPP-4 inhibitors. Finances, in our situation, we have to take this also into account because the anti-diabetic agent ranges from just few rupees to several thousands of rupees. So we have to choose very carefully based on the pocket of the patient. And there are several religious reasons, like people who fast during fasting for Muslims or even for Hindus, the anti-diabetic medication has to be adjusted and the drugs have to be changed based on their routine during those fasting period. Side effects of anti-diabetic drugs are, although most of them are quite safe, very few side effects occur, but if at all they are there, then we have to be careful. And the most important side effect is hypoglycemia. Whether this is a side effect or the drug effect itself, actually, because most of them are known to bring the sugars down, then there may be hypoglycemia, but it doesn't occur with metformin, SGLT2 inhibitors, DPP-4 inhibitors, thiazolinedione when they are used alone. But when we use a combination of multiple oral anti-diabetic drugs, then hypoglycemia might occur more frequently. GI intolerance, a very common side effect of most of the anti-diabetic agents, and foremost amongst them is metformin. Metformin is known to produce all varieties of GI disturbances, and it is very common to see patients on metformin to report to physician, to report to GI specialists for diarrhea, abdominal distension, pain, abdomen, vomiting. These are, and you just stop the drug and the symptoms are relieved. Weight loss is again an important side effect like metformin and SGLT2 inhibitors or GLP-1 receptor analogs. Weight gain generally occurs with sulfonylureas and thiazolinediones. Rest of all the drugs are either weight neutral or they may cause weight loss. Anemia occurs with sulfonylureas. It may occur with thiazolinedione. Fracture, particularly in postmenopausal ladies, have put thiazolinedione into disrepute, and they should be avoided in postmenopausal ladies because of their chances of increased long bone fractures. Pancreatitis, as I told you, can occur with DPP-4 inhibitors. Pruritus is again a very common side effect of sulfonylureas and DPP-4 inhibitors. Headache can occur with any anti-diabetic agent. Genitourinary mycotic infections is a very interesting and recently seen side effect of SGLT2 inhibitors. And this is important to discuss it in this forum because most of our patients who are prescribed these agents, if they are not warned that what precautions they have to take and how they should recognize these infections, they would report to dermatologists or gynecologists. And it should, from your side, it should be always inquired whether they are on SGLT2 inhibitors if they are on these agents, just stop these agents and everything will be fine within few days. Fluid retention can occur with thiazolidinedione, and these should be avoided in people with cardiac issues. Arthralgia is again a common side effect of DPP-4 inhibitors. So these are the side effects which you have to keep in mind. And when patients report to you, think of these side effects before treating these side effects directly. Now, just to give you a very popularly used guideline, how antidiabetic agents should be used. As it says, the first line of therapy in every diabetic, in every type 2 diabetic individual is metformin. And it should be always accompanied by, of course, there is, it goes without saying, it should be always accompanied by lifestyle, comprehensive lifestyle management, which include weight management and physical activity. And if HbA1c is above the target, then you proceed for oral drugs. Now, if there is an issue like atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, if these are the predominant issues in an individual with diabetes, then you go for GLP-1 receptor analogs or SGLT2 inhibitors. Whereas on the other side, you take cost as a major issue, then you are left with sulfonylureas or thiazolidinediones. These are the two very cheap anti-diabetic agents. But currently, just in recent last few months, almost all the recent anti-diabetic agents, including SGLT2 inhibitors and the expensive DPP-4 inhibitors, they have all been manufactured by our giant pharma industry, and it's a great boon for Indian patients. They can get all these newer anti-diabetic agents at dirt cheap price. If hypoglycemia is an important consideration, like in few patients, there is a history of recurrent hypoglycemia. For these individuals, you choose either DPP-4 inhibitors, GLP-1 receptor analog, SGLT2 inhibitors, or thiazolidinediones. In those individuals, you will avoid sulfonylureas. So like this, we decide how anti-diabetic agent should be prescribed. So when you should avoid oral antidiabetic agents and shift to insulin. Of course, it goes without saying, type 1 diabetes. Sometimes type 1 and type 2, there may be some overlap. In those individuals, it is better to go for insulin. If patients is showing persistently high HbA1c on multiple oral drugs. When one drug fail, you add another oral antidiabetic agent from a different class. Then if those two drugs are failing, then you add third drug from another third class. But after generally 2 or 3 drugs, the guideline says you have to shift these individuals to oral, from oral to insulins, because there is no point in adding 4th or 5th oral antidiabetic agent, because you get only 10 to 20% decline in HbA1c when you add 3rd or 4th oral antidiabetic agent. Whatever glucose lowering efficacy you get by first 2 drugs, that is almost 70 to 80%. Then if there are active evidences of infections like UTI, genitourinary mycotic infections, or severe pulmonary infections, or any kind of serious infections, just for minor infections, you may continue with oral drugs, but for all major infections, it is always better, like pulmonary tuberculosis in our scenario, quite common. And all these individuals who are already cachectic, they should be shifted from oral drugs to insulin. Any kind of advanced kidney, heart, liver, or lung disease, these are the individuals who should be shifted to insulin, because mild to moderate kidney or heart failure or liver involvement, you can use some oral agents with dose adjustments. You have to adjust the dose according to the GFR or according to the level of liver enzymes. But in general, if it is moderate to severe, then you better stop oral drugs and shift these individuals to insulins. All hospitalized patients should be on insulin. All patients who are undergoing major surgery should be put on insulin. If there are marked side effects of oral drugs and patient is not able to tolerate, that is another indication to put these individuals on insulin. And persistent weight loss on multiple oral drugs, again, this is one of the indications for shifting to insulin. Thank you, everyone. This is my introduction. मेरे इंट्रोडक्शन में कुछ कमी रह गई थी तो वो मैं पूरी कर रहा हूँ.
Great.
Thank
Yeah,
you.
you have very well briefed the audience and given a fantastic overview of how to manage diabetes in this perimenopause and menopause era, and that too you have really covered all the newer anti-diabetic drugs which has come into the market. And I know you all endocrinologists have shifted from the routine old drugs to these newer drugs, and it is very, very beneficial to the patients. So excellent topic, excellently covered topic, Dr. Shailesh Lodha. I am sure you have covered all the questions. Dr. Anuradha, any comments
Yes.
from your side? Yeah.
It's a wonderful talk, Dr. Shailesh. I really, really enjoyed it. Especially you started that change that we have to go for the 8 defect size. It's not only 3, it is the 8 defect size. So that has changed the absolutely scenario of using the drug. And you have beautifully categorized when to use what drug, and that too the age-wise and the gender-wise. And also we have to see the associated problems regarding different organ, as it becomes a multi-organ involvement because of the diabetes mellitus. And you have beautifully explained the when not to use what drug. Though we as a gynecologist are not that expert. Whenever it is a long diabetes, we cannot. Usually we are managing the early diabetes, the GDM, and still I will like them to attend a diabetologist or endocrinologist before saying yes, you go with it, because he has got or she has got a better vision than us. So that will be a multifactorial things to be learned from you, from the patient, and then to decide what to do. And you have also explained when to use insulin and when to stop oral diabetes. Though in 50 minutes, it's a marvelous exercise you have done to justify your topic. I must congratulate you. And really today, I learned a lot from it. Thank you very much, Dr. Shailesh.
Thank you, madam. Thank you.
Thank you, Dr. Sailesh. It was a wonderful talk. I would just like to know what is the indication where you would like to combine insulin as well as oral anti-diabetic in this elderly women. Is there any indication?
Yes, madam. Actually, insulin and oral drugs are quite commonly combined. When suppose, as I told you, 1, 2, or 3 drugs, when these drugs are failing, instead of shifting these patients totally to insulin, sometimes we put these patients oral drugs and insulin together, and that is a better deal because patients are generally not ready for using more than 1 shot. So with 1 shot, part of their glycemia is controlled, and oral drugs which have some efficacy left, at least they would be useful. So you get a combination of insulin and oral drugs together. As a result, few months or years can be safely passed, and then when oral drugs are totally have totally failed, then it is better to withdraw them and put these patients totally on insulin.
Is it ever possible to revert back to only oral and stopping insulin? Is it ever possible at all to revert them back to only oral and skip insulin?
Generally,
many times people ask.
Generally, this is not done. This is not possible, but it is possible in few individuals. If insulin is started early in the part of diabetes, suppose somebody is starting insulin in 5 or 6 years and who is very obese, if they lose weight like 8 or 10 kgs, then quite often they can be reversed back to oral drugs. Sometimes even if they lose enough weight, it is possible to withdraw oral drugs totally also.
What about vegan diet?
Vegan diet in diabetes, there is no definite role. It is more hyped than it actually works.
Actually, one of my family member has been prescribed because he's too obese. So he was prescribed to have vegan, and he lost 14 kg weight in 3 months.
Yes, for
Madam,
weight reduction,
vegan means
vegan diet
without
is
milk? Without
that is
milk?
for weight
Without
reduction.
milk, yes.
No
Only
animal food.
basically protein like these dals he is using, chillas he is using, but
Yes.
metabolic syndrome is definitely reduced. So I'm impressed. That's why I'm asking.
So you're
Yes,
saying
for weight
stopping
reduction,
curd
it
and
is
milk
very
will
effective.
reduce?
So once
Pardon?
you reduce weight, then diabetes falls
Yeah.
into place.
So this is the
But
way to reduce the weight.
but for normal weight individuals or who are underweight individuals, it will not work.
For obese, very
But
obese.
madam, vegan diet means only reducing milk, na? So milk does, if you don't take even that milk, how will vegetarians get proteins?
Pulses.
Pulses. I
Pulses,
don't
yeah.
know. Because we are a vegetarian family in our house. Many of you are
Mine is
vegetarians.
too.
Yeah, so and all 4 of us in our house are diabetic. So don't tell me it's only milk that is giving us diabetes. I don't know.
That is
But
familiar.
he has been got very much relieved. I'm telling you.
Excuse me, can I share my experience, ma'am, about vegan diet?
Yeah.
Yes, yes.
I'm Dr. Priya Shinde from Chandrapur. There is one app of Breath Wellbeing. They are deleting wheat as well rice as well as milk
Yes.
product from your diet,
Yes.
which includes the paneer also.
Yes.
And for
Try
the
kya?
yes, ma'am.
What to eat then?
Yes, ma'am. There are many things.
Only
There are
vegetables.
many things like there are many pulses which we can made in the form of chillas, and then tofu is there, which is replacing the paneer.
Oh yeah.
And there is soya milk and the almond milk, which we can use in tea or coffee. And it decreases the insulin resistance also.
Sure.
And I have tried this, and I want to know the studies from the sir. If there are any studies which are available, because nutritionists are suggesting this vegan diet for PCOS also. For
Yes.
PCOS patient also, if they omit this wheat from the diet, we can get the better result with the addition of this myoinositones. I'm trying this in my patient, and they're really getting good results.
Even there are wheat from south side. He told me only they are different from the wheat which we are having in our wheat flour. So that is also he told me is very effective.
Yeah, there are different replacement like this diabexi atta also, which is a mixture of different almond flour and all the things. And this is what hapli wheat is there from the south.
I think this can be continued as a very long discussion
Yes,
because
yes,
there are many controversies around this wheat and milk, whether it should be stopped or it should not be. So I think it's time that we now move forward for our next session. Madhulika?
Yeah. इधर आ जाना मौनी
Yeah, so now it's time to move from diabetes to dyslipidemia, which
Now
is
may I
called
request Dr. Anuradha Khanna to please introduce Dr. Vijay Pathak, an eminent cardiologist from Jaipur.
Please show me the
slide, please.
Just show you. Yes.
Yeah. I'm so happy to introduce Dr. Vijay Pathak. Vijay Pathak sir is his age 61 and he's MBBS, MD, DM, very senior professor, cardiologist. Field of interest is coronary, carotid, periphery, angioplasties, stenting, pacemaker, heart failure devices, AICD, non-surgical courses of ASD, PDS, and percutaneous treatment of aortic aneurysm, echocardiography. Hobbies are mountain hiking, tennis, nature. A full-grown, very well-renowned person, Dr. Vijay Pathak. Here you are with us. Please go ahead. Thank you so much.
Thank you, ma'am. It's a pleasure to be hearing Salish. Yes, would you be able to share my screen? I don't have
Yes,
that.
I am sharing.
Thank you. Yes, thanks. So topic on which I am supposed to dwell is for the ladies, dyslipidemias in midlife and perimenopausal women. Next slide, please. So introducing this will be Yeah, dyslipidemia is a major cause of cardiovascular disease. Can you hear me, please?
Yeah, you're audible, Vijay.
Okay. So dyslipidemia is a major cause of cardiovascular disease, which in turn is the most common cause of female morbidity and mortality. A menopausal transition is characterized by decline in estradiol, which causes increase in total cholesterol, LDL, that is low density lipoproteins, and triglycerides, and a decline in high density lipoproteins, which are in a sort protective against the cardiovascular risks posed by rising lipid profile. It's been reported that postmenopausal women are 4 to 8 times more likely to die of coronary artery disease than compared to any other disease targets. So the postmenopausal health demands higher priority. Next, please. So etiology, they can be dyslipidemias or abnormal lipid profiles. Causes could be primary, like genetic disorders. Secondary is like what Dr. Shailesh has already discussed, the diabetes, the kidney problems in form of nephrotic syndrome, thyroid problems as form of hypothyroidism. They may be drug-induced and hypertension associated. Next slide, please. So the target values in the lipid profile is total cholesterol. Ideal is less than 200, and high, beyond which you really need to be sitting up, is more than 240. Low density lipids are the focus of and the target of all the hyperlipidemic agent therapy. Ideal is less than 100, although in certain situations it is less than 40, 55 even. The child is born with LDL level of 20 or less, but as the child grows, the LDL levels are gained, and there comes the risk. Very high is more than 190. LDL generally 100 to 129 is desirable if the patient does not have risk factors. High density lipids are protective, and the levels of more than 60 are high. Less than 40 need attention. If the HDL levels are more than 60, then it is taken that it negates one of the risk factors present on the profile of the individual. Triglycerides are relatively lower on the priority list, but they have their own side effects and problems. Ideal is less than 150. More than 500 is very high, and more than 1,000 can precipitate acute pancreatitis at any time. So LDL is the primary target. The relative risk set at 1 for LDL cholesterol is, which is 40, is every 30 milligram percent change in HDL levels. The relative risk for coronary artery disease is changed in proportion by 30%. As we can see this graph which runs on the vertical section scale as the relative risk, and on the horizontal scale as the LDL cholesterol is going up. So at the stage where LDL cholesterol is 190 or more, the relative risk is 3.7 times or more. Next, please. So the National Cholesterol Education Program from United States, ATP3 and American Diabetic Association guidelines, again, the target is LDL cholesterol. The primary target in both is LDL cholesterol. Secondary target is non-HDL cholesterol. That means total cholesterol minus HDL cholesterol. And tertiary target, according to American Association, is not there. But the American Diabetic Association recommends that triglycerides also be the target of treatment. Both guidelines recommend statins as the drug of choice, as I'll be coming on later on. Next, please. So, as I said, LDL cholesterol is the primary target, and a surrogate measure of total atherogenic lipoprotein burden is non-HDL cholesterol. Targets in patients at risk are risk stratified. HDL cholesterol have levels have inverse relationship with the risk for coronary heart disease in men and women. A newly emerging risk factor is lipoprotein A or little lipoprotein. This is also coming up as a new risk factor recently. Next, please. So next slide, please. So what is happening in menopausal women or perimenopausal women is promotion of the situation or the conditions or the milieu which lead to precipitation of coronary artery disease. So in women, there is secretion of, at the time of menopause, because of withdrawal of favorable hormones and the aging effect, there's pro-inflammatory cytokine release, increased visfatin, decreased adiponectin, and increased free fatty acids. This quartet leads to insulin resistance, and insulin resistance is one of the components of metabolic syndrome, which is comprised of insulin resistance, hyperglycemia, dyslipidemia, and hypertension. So going to all these quartet, the risk factor goes high. What are the effects of dyslipidemia? See, metabolic syndrome, like I've already said, hypercholesterolemia, triglyceridemia, mixed hyperlipidemia. This tips the balance in favor of forthcoming coronary artery disease. They are proatherogenic ApoB containing lipoproteins, VLDL, intermediate density lipids, and low density lipids. And whilst the HDL and anti-atherogenic ApoB containing lipoproteins lose their effect. So this leads to enhanced arterial cholesterol deposition, attenuated reverse cholesterol transport, and accelerated atherogenesis. Next, please. So lipoprotein levels across lifetime, a woman's lifetime, women experience a number of hormonal changes throughout their lifetime, including those changes associated with puberty, menarche, pregnancy, and menopause. At birth and throughout childhood, serum cholesterol levels are similar between the boys and girls. Both genders, total cholesterol starts at about 65 milligram% at birth and increases by 2 years to 165. LDL levels tend to increase both in men and women, but after 20 years, but they do more rapidly so in men. Starting during puberty and continuing in early adulthood, HDL cholesterol levels decrease in men while staying constant in women. That is the reason why they pick up heart disease not very frequently in premenopausal stage. This HDL cholesterol reduction beginning at puberty and sustained throughout adulthood translates into observed approximately 10-point lower HDL cholesterol in men as compared to women. During pregnancy, the levels of hormones, you all would know better, levels of number of hormones including HCG, beta estradiol, insulin, progesterone are significantly increased. And these spikes in hormone levels are associated with an increase in total cholesterol, triglycerides, and LDL cholesterol. Similarly, pregnancy is associated also with an increase in the levels of total HDL cholesterol, HDL2, and apolipoprotein A1, which is maximum at the week of 25 weeks of pregnancy. These HDL cholesterol are helpful and beneficial against coronary artery disease. Possibly hypothesized mechanisms for postpartum decrease in HDL levels include an increase in pregnancy-related androgen, dehydroepiandrosterone sulfate, which has also been associated with low HDL levels in women with PCOD. Additionally, prolonged insulin resistance and pregnancy-induced diabetes may explain the observed decline in HDL cholesterol following pregnancy. Several epidemiologic studies have shown that postmenopausal women tend to significantly different lipid profiles as compared to premenopausal women. Framingham study is one of the largest studies carried so far. Investigators have documented an increase in total cholesterol levels that coincided with menopause, suggesting a causal role of menopause in the evolution of coronary artery disease. Various studies have have noted menopause to be associated with the transition in LDL particles to be more atherogenic, smaller, and more dense particles, and they impart more risk of coronary artery disease as a presence of more dense particles. Total HDL cholesterol and HDL2 also decrease in postmenopausal females. Elevated LPA levels have been associated with increased coronary artery disease and has been reported increase in women following total hysterectomy and oophorectomy. So these are the various levels depending on the age. So younger than 19, total cholesterol is 170, it goes to 200 when beyond 20 years in men and women. Next, please. Cardiovascular effects of hormone therapy. Now, oral contraceptives use is known to alter lipoprotein levels depending on the relative concentration and presence of estrogen and progesterone. Estrogen component found in OCPs tends to increase HDL cholesterol, HDL2 and triglyceride levels and decrease LDL cholesterol levels. Reverse is with the estrogens, with the progesterones. In postmenopausal women, use of hormone replacement therapy with unopposed estrogen associated with significantly higher HDL cholesterol and HDL2 and lower HDL compared to premenopausal females. Based upon various randomized control trials like heart and estrogen progestin replacement study, Women's Health Initiative study treatment guidelines were subsequently updated with the removal of recommendation for use of HRT in women to prevent coronary artery events because of increased risk of stroke and cardiovascular events on follow-up. There was a time when it was propagated further. Now, Framingham scores have been developed to calculate the 10-year, 20-year risk of coronary artery disease based on the age, cholesterol, HDL levels, and systolic blood pressure, also taking into consideration the smoking and other risk factors. Next, please. So risk stratification according to today's dyslipidemia education is very high, where already cardiovascular disease is there. In addition to multiple risk factors, especially diabetes, the other risk factors would be smoking, hypertension, stress, and obviously dyslipidemia, metabolic syndrome, or pre-existing acute coronary syndrome. High risk is where the risk, 10-year risk is more than 20, there where the patient already has coronary artery disease or an equivalent like diabetes, or they have peripheral arterial obstructive disease, or renal involvement. Moderately high is more than 2 risk factors, and the 10-year risk is 10 to 20%. Moderate is 10-year risk is less than 10%, and low is 0 to 1 risk factor. So, next, please. So this has been the progress according to the National Cholesterol Education Program, started in 1988, where diet was the initial treatment and low-dose non-statin monotherapy was instituted. In 2001, high-dose statin combination therapy was imparted according to the ATP3 recommendation. So increasing aggressiveness of cholesterol-lowering therapy has been there. Next, please. So this is the risk. These are the goals according to the different risk categories. So very high risk, the LDL goal goes less than 70, and even now, even less to less than 55. In high risk, it has to be 100. Now, even now, it is less than 70. Moderate high risk is less than 100. Moderate risk is less than 130, and low risk is 160, but it is preferable to have it less than 130. Lifestyle modifications are advisable in all situations, and all patients, all people with high risk and very high risk are subjected to drug therapy. Next, please. So this is only one of the primary prevention algorithms where multiple risk factors, where there's more than 20% risk, including all the coronary heart disease risk equivalents, the level to which consider the drug therapy is more than 100 and primary goal of therapy is less than 100, actually less than 70. Next, please, because this is an old slide. Next, please. So this is one of the recent which speaks out the same categories, and this is atherosclerotic cardiovascular disease risk. So statin benefit groups are those who have clinically cardiovascular disease or the elevations more than 190, diabetes or no diabetes with the risk score more than 7.5%. Next, please. These were the guidelines according to which we have evolved further. The next slide. So 2019, they have categorized the changes in the LDL goals to and the very high. This is according to the European Society of Cardiology. So very high risk where the scores are assessment is very high risk, then LDL goal is less than 55 and reduction of equal to or more than 50% of the baseline LDL. Among the high risk, it is less than 70 and again more than 50%. Moderate risk, it is 100 and low risk, it's less than 116. Next, please. So according to the current dyslipidemia management guidelines, risk categories to inform treatment decision is the common features, diet and lifestyle interventions, and maximum statin therapy for high-risk patients. Differences, just a minute. The differences, key differences are US guidelines work according to only randomized trials and treat to LDL cholesterol target versus using statin regimens to produce a 30 to 50% LDL reduction. Fewer options for combination, American guidelines, fewer options for combination lipid lowering therapy. Evidence for specific dietary interventions is according to Predimed study, and result shows in the primary prevention 30% reduction in major cardiovascular events, that is myocardial infarction, stroke, or death from cardiovascular causes in both Mediterranean diet groups. Now, Mediterranean diet mainly involves nuts and fruits, and along with that, highly virgin or extra virgin olive oil in the food. Next, please. So this is again the target scores where very high with diabetes and all that kind of which I've already discussed according to the levels of the LDL cholesterol. Next, please. So these are the recommendations. So prescribe statin up to highest recommended dose, which could be for the atorvastatin could be 80 milligram and rosuvastatin could be 40, or highest tolerable dose, because the statins have side effects like myopathy, like muscle pains, and rise of liver enzymes. So this is a class 1 indication to prescribe up the highest recommended or highest tolerable dose. In case of statin intolerance, aziramide or bile acid sequestrants may be used in combination or alone. If the goal is still not reached, statin combination with cholesterol absorption inhibitor like BAS should be considered. If the goal is not reached, statin combination with a bile acid sequestrant can be used. At patients at very high risk with persistent high LDL despite treatment with maximally tolerated statin dose, a PCSK9 inhibitor may be considered, which is one of the newer therapies, but it is injectable and hence has to be given and very expensive, so it has to be given with great precaution. Next, please. Next. So primary prevention conditions warranting all risk groups, it is recommended that it should be more than 50% reduction of LDL cholesterol in individuals in whom treatment is initiated to lower the risk of cardiovascular disease. Recommendation is moderate quality evidence. Alternate target variables are ApoB, which is a kind of lipoprotein, or not non-HDL cholesterol. Next, please. These are the groups of drugs which are commonly used, and the commonest is the statins, which are HMG-CoA reductase inhibitors. This inhibits cholesterol synthesis in hepatic cells, resulting in upregulation of hepatic LDL receptors. And the goal is reduction of LDL cholesterol, rise of HDL, and reduction of triglycerides. The problem is rising CPK, as I said, and myopathy, sometimes rhabdomyolysis. The less frequently used drugs are bile acids binding resins. Fibric acid derivatives are mostly used for triglyceride reduction. Nicotinic acid is a group of drug which is used for low HDL. So this is liable to increase the HDL. And then cholesterol inhibitors, absorption inhibitors, which also have their own side effects. But ezetimibe as a combination therapy is nowadays recommended along with statins in case LDL is not controlled. PCSK9 inhibitors are again newer group of drugs which are given as a monthly dose of intramuscular injections, and they are extremely expensive and have to be used with a great precaution. Next, please. So that is all about the recommendations. This is the American Diabetic Association recommendation: statins and then bile acid binding resin of fenofibrate. Increase HDL if the goal is then fibrates like nicotinic acid or fibrate like fenofibrate. If you want to lower triglycerides, then fibrates again. And for combined hyperlipidemia, then combination choice of these medicines have to be used. Next, please. Now, what actually should come before all this is non-pharmacological treatment, because this addresses commonly all people who are at risk, and it has to do with lifestyle. So therapeutic lifestyle changes have to be brought about. One of them is the smoking cessation. Now, smoking increases the risk of coronary artery disease by 4 to 8 times, and naturally smoking or tobacco in any form has to go off. Weight loss. Now, overweight is associated with many ailments. Hypertriglyceridemia is one of them. High cholesterol is another. Metabolic syndrome is the third one. But obstructive sleep apnea, which is attended by arrhythmias during sleep, refractory hypertension, refractory diabetes, and sudden cardiac death. So weight loss is a very important pivotal point where the prevention of coronary artery disease has to be brought in. Dietary habits have to improve. That fast food should be avoided, and high olive oil, or I'll just in the next 1 or 2 slides, I'll explain the kind of diet that has to be taken. Lifestyle modification will involve diet, exercise, smoking cessation, and behavioral techniques, means the stress reduction, relaxation techniques. This should reduce adipose tissue, androgenicity, and insulin resistance. This will improve dyslipidemia, depression, and quality of life. Next, please. So for dyslipidemia, for exercise, aerobic activities like walking, jogging, cycling, and swimming. Resistance training means dumbbell or weight training, weights twice a week using light to moderate weights up to 10 to 12 repetitions. According to the need, intensity can go up. It has to be built up. Frequency is 5 days per week. And duration is to begin week workouts at 15 minutes and build it up to 30 to 60 minutes per day. Goal is to exercise for 150 to 200 minutes each week. And programming for clients can be done who have abnormal lipid levels, but who are free of other health conditions. Next, please. So these are the types of exercises. As I said, warm-up exercise, light walking after stretching. Exercise intensity is of max. If we look at the heart rate, it should be not more than 55 to 75% of maximum heart rate. Maximum heart rate is 220 minus the age. That is the maximum heart rate. Exercise duration in the warm-up 5 to 10 minutes and 4 to 6 days a week. Main exercise should be speed walking, power walking, cycle ergometer, stepper, cyclone, light hiking, even swimming. Main exercise has to be 30 to 60 minutes, and it should not be abandoned immediately. It should have a cool down period with stretching after light walking. This should take about 5 to 10 minutes. Next. So the diet therapy, the last diet therapy is therapeutic lifestyle changes. The diet should contain fats, about 25 to 35% of all calories, carbohydrates, 50 to 60% of all calories, and fiber, 20 to 60 grams per day. Now the saturated fats, among the fats, has to be less than 7% of total calories. Polyunsaturated fats up to 10%, and mono unsaturated fatty acids has to be up to 20% of all calories. Proteins have to be 15% of calories, and cholesterol less than 200 milligram per day. Next, please. About the diet to reduce the low density cereals, whole grains to be preferred, vegetables, raw and cooked vegetables to be used in moderation is potatoes, legumes, lentils, beans, fava beans. A nutritional specialist can tell better. Fruits, frozen or fresh fruits, and sweets should be non-caloric sweeteners, or the inverted sugars should be used. That's better. Thank you so much for your patient listening.
Thank you very much, Dr. Pathak. Your talk was excellent and we enjoyed a lot and also learned a lot also. And we should be, all menopausal, perimenopausal women should be very careful for dyslipidemia. And we all know in our menopause clinic, we are getting this establishment of working out for dyslipidemia, seeing the patient. And as you said, hormonal therapy, whenever it is required, it can be given safely up to 10 years after menopause. And after that, it is not that safe as per global consequences. And also regarding diet and exercise, you have mentioned beautifully about the ratios of LDL, HDL. That too is very, very important to understand. And you have shown the correlation of obesity, dyslipidemia, and diabetes. That too is very, very important to understand, because if you are having dyslipidemia, you are going to have diabetes mellitus as well. So these two comorbidities, they go together. That's what I understood with your excellent talk. And regarding simvastatin, you have mentioned that anyone can be given, but there are side effects. I have seen in my colleagues also, those who are taking, there are myopathies developing, and it is so much that one of the colleague was in the bathtub and he couldn't took out of that, and it was an emergency. So that is to be very, very careful. They should be told that what should be their lifestyle so that they should not catch up in such emergencies. So I learned a lot, and this definitely going to improve my prescription of the patient. But I will always like to have their workup from a senior person like you regarding dyslipidemia, and then to continue regarding the treatment. Thank you so much.
Thank you. Pathak, it was an excellent talk. Just one question. Which oil is best when we are having dyslipidemias?
As I said, I think olive oil, extra virgin olive oil is always.
But some say that it cannot be used for cooking, like we Indians give tadka and all that.
I've never prepared a diet actually, but we can use some. What we say is mustard oil can be used.
Okay.
Mustard oil, but we must be changing the oil in a few months each time. That's what is recommended actually.
Even if we are using olive oil, you mean to say that we should go on rotating to mustard, groundnut, soy?
That's right. That's right.
I think every day.
Every month.
No, every few months. Every
few months we should keep on changing. And there is so much controversy about the egg yolk. So what is your recommendation as far as the cholesterol and egg yolk is concerned?
What our learning goes, ma'am, is that we should avoid egg yolk, consume egg white, because that is protein. Egg yolk is not healthy.
Okay. In Kerala, is there any increased incidence because they're exclusively using coconut oil?
Yes.
Yes. Coconut oil contains lauric acid.
Ah.
And it's supposed to be very good. It's common BBC.
That is what I want to. Any significant significance of that or any benefit of that?
They say lauric acid is beneficial for your heart.
Dr. Sunila wants to say something.
No, I just want to congratulate both the speakers. Wonderful. But just I would like to add few things. Number one, related to I have listened carefully about the HERS trial and the WHI trials, but since now we have in our basket of armamentarium good salts of progesterone, so I think these women can be safely prescribed even with dyslipidemia. The lipid-friendly MHT is there, dehydrogesterone in our basket. So various studies have come, and I have been using also with the careful, lipid measurements, lipid profile. Number one. Number two, I heard the discussion. It was always interesting discussion when we discuss about the oils. So I think in every day from morning till night, we can change the oil. Everything from the morning, whatever in the breakfast you have used, change in the lunch, then change in the dinner.
No, not practical, madam. Because you don't enter the kitchen, you're telling me this. Because one oil you use and remaining oil you cannot throw. You put it in the same this thing. And
I'm not saying this. I'm saying if one dish is prepared in one oil, other dish should be
नहीं वो oil का ऊपर दूसरा डिश डालेगा तो वो ऐसा fraud आता है. हमारा घर में हमेशा होता है. कभी-कभी by mistake you use another oil, it starts frothing like a soap. You can't.
No, I'm not saying in the same dish. I'm saying if you are preparing 5 dishes in a day, so every dish.
High hopes, madam. 5 dishes in a day.
No, I think Dr. Shobna, what Dr. Sunila is saying, like in our house, what we do is that we make the dry vegetable in mustard oil and gravy vegetable in regular oil. And when you put the tadka in the dal, that is pure ghee. So,
and if you are eating salads, you can put virgin olive oil. And if you are eating like curries and all those South Indian dishes, then you can use coconut oil. This is what I am doing actually. That I'm not saying which I'm not doing. I'm doing this. That's why I'm saying this.
Yeah, even I am doing this. Let's try. In my house also, it's same thing. Some vegetables are made in mustard oil.
Absolutely. I see to it that the five leafy vegetables should be there, 5 types of oil should be there.
Can I ask you a personal question, Dr. Sunila Khandelwal?
Yes, please.
What is your HDL level?
Luckily, cross my finger, both are within normal range.
So it's all because of the various oils. See, you have a
it's not only the various oil. Of course, exercise and all those things. I know. By the grace of God, I would say that.
Because of hypothyroidism, I used to have my lipids were bad, but now they have improved.
I think this topic will go on and go on, but I really congratulate. I learned a lot from both the speakers. Wonderful, and thank you, Anju, and thank you, Shubha, and thank you, Dr. Shobna, for just making them be here with us. Thank you so much.
Thank you, chairpersons, for chairing this session and speakers for the wonderful talk.
Thank you very much, Dr. Madhulika. At present, I have to go somewhere, but I will be on mobile. Thanks a lot. And thanks, Dr. Shobna and Sonia.
Thank you. Before starting panel, I would like to show a video clip made for public awareness. Yeah.
May I beg your leave, ma'am, because...
Yes. One sec. You take just for 5 minutes, if you could see the video and leave.
Okay.
We made a video clip for public awareness. As we know that previously the life expectancy of a woman was almost around 50 years. Now it has increased up to 70 years. And it might reach up to 90 years in future. So our message is that we should live a long life without comorbidities or without its complications. So that a woman can be fit at 40, strong at 60, and independent at 90. So knowledge and prevention of comorbidity is highly important for a long healthy life. न देखो मेरे चेहरे की झुर्रियों को इस तरह ताज्जुब से, न देखो मेरे चेहरे की झुर्रियों को इस तरह ताज्जुब से, लगाए हैं उम्र ने बरसों मेरा ये श्रृंगार करने. So we have made this video in Hindi, but soon we will make it in English also. So please play the video, clarinet people.
डॉक्टर साहब गुड मॉर्निंग. गुड मॉर्निंग.
नमस्कार.
दोनों बहनें आ रही है और सुनीता तुम तो बहुत फिट और फाइन लग रही है.
आज इसको लेके आई हूँ मेरी छोटी बहन को.
मुझे बहुत प्रॉब्लम है.
आप ऐसा है डॉक्टर साहब, मैं आपको एक बात बता दूँ. मैं हूँ 66 साल की, ये है 50 साल. इसके हस्बैंड को तो पैसा कमाने के अलावा कोई काम नहीं है. इसका बिल्कुल ध्यान नहीं रखता, ना इसको कुछ कहता है. और ये चाहे तकलीफ में, मैंने कहा मैं ही तेरे को लेके चलती हूँ. अपने डॉक्टर साहब से बहुत पुराने संबंध है, घरेलू संबंध है, तो मैं इसलिए तुमको इनके पास लेके आई हूँ. और ये मेनोपॉज एक्सपर्ट भी हैं. तो तुम्हारा वही टाइम चल रहा है, मेनोपॉज आने वाला है. मैंने कहा मैडम के पास नहीं ले चलती.
कुछ कुछ घुटने में तकलीफ होती है, एकदम उठा नहीं जाता है, कभी कमर दर्द होती है, कभी चलते चलते ऐसा लगता है कि घुटनों में बहुत दर्द हो रहा है. काम करने की कैपेसिटी कम हो गई है पहले से ही, मैं जल्दी से काम नहीं कर पाती और नींद भी ज्यादा. आपकी कोई फैमिली हिस्ट्री है? ऐसा है, मेरी माता की तो 84 साल की, फिर सारे काम करती है, बहुत बढ़िया. और नानी भी 90 साल की थी, जी मतलब 90 साल तक थी, एकदम एक्टिव. फिर उन्होंने मरते तक आके इनमें समझ लो कोई हेल्प देती थी. मरते तक फिट रही, सारा काम करती थी, कपड़े तक धो लेती थी. दादी जो थी ना हमारी, डॉक्टर साहब वो तो बिल्कुल आप समझो 40-45 उम्र के बाद बूढ़ी भी थी, ब्लड प्रेशर भी था, शुगर की तकलीफ भी थी उनको. वो तो समझो कि आप पड़ी रही खाट पे. जी तो हो भी 85 साल 86 साल, पर खाट पे नहीं हो. अभी इससे सेवा उससे सेवा, बहुएं सब सेवा ही करते रहे दादी की. ये गर्भावस्था के दौरान ऐसे तो कुछ नहीं था, लेकिन शादी के बाद से मेरा वेट बढ़ने लगा. और जब मैं प्रेग्नेंट हुई, डॉक्टर ने बोला भी था कि मेरा थोड़ा ब्लड प्रेशर ज़्यादा है. और एक बारी सेकेंड बारी में ऐसा लगा था कि शायद शुगर भी है. चेकअप करवाया नहीं, क्योंकि लास्ट में कराया था जब 3 महीने बाद गई थी, तब कराया था. उन्होंने कहा अब नहीं है, तो उसके बाद ब्लड प्रेशर देखिए. प्रेगनेंसी में एक बार अगर ब्लड प्रेशर हो जाता है तो फिर इससे आगे भी बढ़ने के चांसेस रहते हैं. इसमें समय समय पे जो है अपना ब्लड प्रेशर चेकअप तो करवाना ही चाहिए. तुम गई कब डॉक्टर के पास? तुम्हें फुर्सत कहाँ है अपने घर से? ऐसा है सुनीता, मैं इसकी कुछ टेस्ट डॉक्टर साहब आप सब टेस्ट लिख दो अच्छे से, कोई तकलीफ नहीं है, टेस्ट सब करा लेंगे. बीमारी आप जो पता लगा. हाँ ठीक है. विनीता 50 साल. टेस्ट करवा लो और इसकी अपन देखते हैं प्रॉब्लम कहाँ पे. ठीक है. अच्छा दवाई तभी देंगे आप मुझे? हाँ इसके बाद ठीक है डॉक्टर साहब. नमस्कार डॉक्टर साहब, सब जांचें करा ली जैसे आपने समझाया था ना, हमने वैसे सारी जांचें करा ली. अब आप बिल्कुल देखो डॉक्टर साहब और बताएं हमें कि क्या ठीक है बेटा. इसके हीमोग्लोबिन को ठीक है, तुम्हारा HbA1c लेवल थोड़ा सा ज़्यादा है, 6.8 के करीब. इसका क्या मतलब? इसका मतलब होता है कि तुम प्री डायबिटिक हो, आगे चलती तुम्हें डायबिटीज की प्रॉब्लम हो सकती है. और दूसरा तुम्हारा ट्राइग्लिसराइड. अभी तो संभावना ही है ना डॉक्टर साहब, अभी बीमारी की शुरुआत है. और तुम्हारा जो ट्राइग्लिसराइड है यानी शरीर में जो वसा की मात्रा है वो तो अपने को अभी से ही ध्यान रखना पड़ेगा, जिससे आगे चल के ये बीमारी. इसके लिए आप इसको समझाइए
तुम वॉक योगा वगैरह करते हो, कुछ एक्सरसाइज तुम आज से ही शुरू करो, मॉर्निंग वॉक के लिए जाओ, योगा करो और तुम हेल्दी टाइप और जो सफेद चीजें हैं उसे पूरी बनाओ, लाइक जैसे नमक है और चीनी है, ये बहुत कम करो। चावल भी बंद करना पड़ेगा। हाँ, चावल भी बंद कर दो, पर अगर फिर भी तुम्हें बहुत इच्छा हो तो सप्ताह में एक बार बाहर निकाल कर भी चावल खा सकते हो। सब घी तेल भी बहुत कम करो, गला हुआ में चीजें बिल्कुल कम कर दो, नहीं तो आगे चल के कॉम्प्लिकेशन होंगी और फिर हमारे कुछ ज्यादा प्रॉब्लम होगी। तो सीधा तुम इसका ध्यान रखो, इसका ध्यान नहीं रखते हैं, बिजी रहते हैं, तो प्लीज आप इसका ध्यान रखें। मेरे लिए तो ये बेसिक हमारे है, तो डॉक्टर साहब आप चिंता मत करो, आप अच्छे से समझा दो। तो तुम्हें एक तो एक्सरसाइज करनी है सुबह उठ के, एक अपनी डाइट का ध्यान रखना है और कैल्शियम और विटामिन डी ज्यादा लेना है। कैल्शियम का मतलब मेरी प्रोडक्ट में बहुत ज्यादा कैल्शियम होता है, तो वो भी लो फैट मिल्क लेना है। ऐसा नहीं कि तुम भैंस का दूध ही पीने लगे, तो उससे इसका मोटापा और गाय का दूध पिलाओ, लो फैट में वो लो। और विटामिन डी भी, विटामिन डी की गोलियां भी आती हैं, उसका सिरप भी। आप मुझे मैं सारी दवाइयाँ ले लेती हूँ, तो ये दवाइयाँ लो तो तुम्हारी ये जो प्रॉब्लम्स है काफी हद तक कम हो जाएगी। मैंने तुमको प्रिस्क्रिप्शन बना के दे दिया है, इससे इसकी हालत काफी पहले और जो कि हमने 50 साल तक और आजकल जो है उम्र है वो 70 साल तक की हो गई है और धीरे धीरे आगे चल के भविष्य में ये 90 साल की हो सकती है। तो हम लोग ये चाहते हैं कि जो जिंदगी है अपनी बिना किसी बीमारी के अच्छी तरह गुजर जाए और हम लोग एक स्वस्थ और लंबा जीवन जी। आपके कहने का मतलब कि उम्र लंबी हो पर बीमारी के साथ ना हो, बीमारी मुक्त जीवन, जिससे कि हम अपनी जीवन ज्यादा एंजॉय। आपकी बात हमें बहुत अच्छे से समझ में आ गई, बहुत ही बढ़िया, आपने अच्छे समझा दिया। विनीता समझ में आ गया, तुम नानी जी की तरह रहना है, दादी की तरह नहीं, सुनीता दीदी की बातों को ध्यान से सुनोगी और ये जैसे जैसे है वैसे वैसे और जो थोड़ी बहुत मैंने तुम्हें दवाइयाँ वो तुम टाइम से लेती रहो, तुम्हारे देखना कायाकल्प हो जाएगा। मैं चाहती हूँ कि सारी जो औरतें हैं फिट एट 40, स्ट्रॉन्ग एट 60 एंड इंडिपेंडेंट एट 80, 80 साल की उम्र में भी आपको किसी के ऊपर बोझ ना हो, आप अपना सारा काम खुद कर सकते। ये तभी पॉसिबल है जब अपन अभी से ही ध्यान रखें। डॉक्टर साहब थैंक यू। मुझे स्लाइड शेयर करनी है, डॉक्टर मुझे सुनिए और इसके दिखाना।
Madhulika, you can invite the.
Yes. Now would like to invite moderators for the panel discussion on aging gracefully. First of all, I would like to invite Dr. Anju Soni. As you all know, she needs
no introduction already.
And Dr. Shubha Sethia. She is a president of Jaipur Society.
Let's move forward, Madhulika.
May I request all the moderators to kindly introduce the panelists.
Can you just stop sharing the screen?
Yes, yes.
Yeah, please. Thank you very much for everybody for being here. And we are slightly late, but I'm sure I'll be able to. Are my slides visible?
Yes, yes. They are visible.
Yeah, 1 second. Just give me 1 second. So today we have with us very expert people who will be giving us their inputs today. And I'm very, very happy to introduce the moderators. Dr. Shobna Mohandas, we have already introduced. She is an expert in the field and president of Indian Menopause Society. Dr. Seema Shafa Sharma, professor and unit head she used to be with Mahatma Gandhi, but now she's with the other hospital, and she's also done a lot of research work. Professor Revati Janki Raman, again, another learned person. She's been vice president Foxy South Zone in 2016. Dr. Switi Soni, a senior obstetrician consultant at Saket Hospital, and Dr. Pankari Goyal, a young star of our Indian Menopause Jaipur Menopause Society, and she is director of Asta Hospital. So welcome all experts and so we all know that aging gracefully is often used as euphemism with, and perhaps aging gracefully does not necessarily have to be referred to age or appearance, but it is rather an attitude people have as they go through the various stages of life. So what we initially thought were looking old but embracing it, showing signs of aging but still powering forward with life, and then now women who choose to grow older without undergoing any aesthetic procedure to help them maintain their look, that is now. It means that taking steps to make your outside appearance match the way you feel inside, and if you feel energetic, youthful internally, then there is no shame in getting any aesthetic procedure. And then ultimately it comes to personal needs and desires. And if you are confident about getting yourself any treatment, please go ahead. So WHO defines the quality of life as an individual perception of their position in life in the context of culture, value system in which they live in relation to their goals and expectation and standard concerns. So according to WHO, the quality of life is regarding the physical, psychological level of independence, social relationship and environment, of course, spirituality and religion and personal beliefs as per the patient's need. So there is a case who is an 47-year-old, and she heard from a colleague that who has been suffering from menopausal symptoms. She thought she could beat it by consulting a doctor beforehand. She had never heard of a film star even suffering from any of these problems. Maybe their doctor prevent them from experiencing menopausal symptoms. So this case is to Dr. Shobna Mohandas. And Dr. Shobna Mohandas, could you address this case, please? Dr. Shobna, are you there?
Yeah, yeah. Sorry, I forgot to put on my video and audio. Sorry. Yeah. So she's 47 years and she has seen somebody. That's all that she's seen. And I don't, she herself does not have any menopause symptoms she's talking about, right?
Yes.
Yes. So if she has no symptoms, you do not have to give any medications. She just has to be informed about what are good phytoestrogens, if at all. Include them better in their diet if it is not already included, like chana dal and moong dal and things like that. Not too much to worry about it, but if she can have soya in her diet and things like that, have good exercise, good vegetables, good calcium and calcium tablets in her armamentarium of tablets. That's about it. Without any actual manifestation of hot flashes, there is no need to give HRT. Actually having no osteoporosis, no need to give HRT, nothing. Just talk about diet and things like that. That's enough.
So, ma'am, well said that midlife, when there is age advancing, there is declining immunity, increasing risk factors, and of course, chronic diseases. So, what are the issues in menopause?
Menopause, is it for me, Anju, or you want to ask?
Yeah, it's for you. Your question is continuing.
Yeah, in issues in menopause are that many of them do have hot flashes. They just they don't think of it as hot flashes. They come to you with pruritus vulva. They come to you with abdominal pain. They come to you with lot of bleeding problems. But when you prominently ask them whether you have hot flashes, when a woman in that age group comes to you, it is your duty to always ask if you have hot flashes. Nowadays, I'm doing it because I've got my hot flashes form here. But even otherwise, you're supposed to ask that. And quite often, your prescription for AUB will change when that person will have hot flashes from pure progesterone to adding on to an estrogen into it. And if you ask for it, then, you have to ask for this. And when you are talking to her, when she talks about aches and pains, then you have to, a woman in menopause, you have to ask history of fall in the family, things like that. Just chatting, you can ask all this. Mood changes are there in menopause, but they cannot be treated with HRT. You have to give antidepressants. And when you have a chronic pelvic pain,
ma'am, we will go into the detail. I just wanted to
there can be mood changes, but then don't expect HRT to treat it. That's all. But you have to ask for mood changes. Why? Because if there is undiagnosed depression, your chronic pelvic pain will never get cured. Definitely. Unless you treat that depression, your leg pain, body pain, nothing is going to go. So you have to ask for history of sleeplessness and depression. That is there. That's all. A cardiovascular risk is less, osteoporosis is there, Alzheimer's
so,
is
madam,
there.
Do you do the asymptomatic perimenopausal need any therapy? Is there something like window of opportunity? Would you just say what is there any role of these investigations? What I have mentioned.
They do not need any therapy. General checkup, yes, there is a need for that. Breast examination, yes. PSPV without any symptom. Nowadays, self-testing HPV kit is coming. Whether PSPV should be done for all asymptomatic women, I wouldn't really force them to do it. Investigations, how far to go. Lipid profile, BP, blood sugar, thyroid, it's good to do. Screening, mammogram.
If you can stop video well.
Sorry?
Dr. Shobha.
Yeah.
Internet connection is okay? Your
my internet connection is okay, but yours is breaking for me.
Okay. Fine. So then what are the investigation minimum you will get done?
I told you you have to get I will get a thyroid profile, HB, sugar. You have already written there, that's all. Dental check I normally don't do. Let me tell you this. If it is necessary, I don't know whether Dr. Anju wants it done, but I never look at the teeth of a patient. I don't know whether it should be put in guidelines, because in the clinical practice guidelines of MITA, even stool examination has been put. So I disagree with these guidelines, really.
Madam, is there any place for FSH, BMD?
No, not routine, not routinely. BMD is not available anywhere unless high-risk patients are there. BMD is not necessary.
So thank you, madam. Over to you, Shobha.
Yeah. So we have discussed that there is a general menopausal woman who comes to us. But as the times are changing, we have seen that the medical requirement of the society has changed. We are moving from an era where people used to think of immortality. They wanted to live longer. And to attain this goal, we have seen various phases in the health services. There was one phase where we were looking after the communicable diseases. Then came a phase when we were looking after the non-communicable diseases. But in future, what we are going to see is a time when people are now having a very good longevity. So with longevity, we cannot avoid the side effects of aging and the effect of aging on various body systems. But what we are now bothered about is that with aging, we want to decrease their disability associated life years. So our focus is changing from non-communicable diseases to from communicable to non-communicable diseases, and now prevention of not only premature mortality, but premature morbidity and disability associated life years. And so along with longevity, we have to start explaining them about healthy lifestyle measures and prophylactic and preventable measures where their chronic diseases can be prevented, so that we can decrease the disability associated life years and compress the morbidity. So Dr. Revati, I would like to ask you, what is healthy aging? Is healthy aging compression of morbidity? And what do we really mean by compression of morbidity?
Actually, the longevity is now increasing. Women, not only total population, women's lifetime is increasing. And just it is not enough increasing the number alone, a healthy life, that is very important. And invariably, as we age, necessarily comorbidities and other diseases, non-communicable diseases are likely to occur. We want to reduce the duration of the diseases towards the end of our life, so that the length of the time we are living, the maximum will be in a healthy period. Okay, so the total period of morbidity because of the diseases we have to prevent, so that it will be compressed, and that will be for only shorter time, so that the longer period of our life will be enjoyable without any diseases, healthier life. That is compression of morbidity.
So as you rightly said, that what is compression of morbidity is that we will delay the onset of the disease. So once we delay the onset of the disease by using preventive measures, maybe primary, secondary, or tertiary prevention. Tertiary we do not consider here, but primary and secondary prevention should be the goal of, should be our goal whenever any female in perimenopause or menopause comes to us, so that morbidity is delayed and so that the total duration of her life where she's spending in morbidity can be decreased. And this is a concept which was given to us by James Fries. So we will take all preventive measures and decrease or compress the time that she spends with disability. So this is a chart which shows that earlier what used to happen is that this is the period when she would start with onset of morbidity, and this is the death. With life extension, morbidity onset was at the same time, death was delayed, and the total time that was spent in the phase of morbidity was prolonged. But now what we want is, we want to delay this morbidity. We want to shift this morbidity from year to year. And so the total life spent in morbidity period of the patient is decreased. And this is our focus in modern medicine, that we will decrease this gap and delay the morbidity till here. And this is where we will focus and what we will talk in our future questions. Dr. Revati, how can we compress this morbidity and quality of life? Because we always say that 70 is the new 50 and 90 is the new 70. How can we bring this about?
Actually, by various preventive measures, you can do that.
Yeah. So what would you suggest as preventive measures?
By identifying the risk patients, and
Yes.
And also we have to screen them and identify the diseases earlier and then treat, and advise some lifestyle modifications, both in the way of diet, exercise and all. And suppose they have got the risk behaviors like smoking, alcohol and all those things, you have to identify that and ask them to get rid of that. And whenever identified, either earlier, either a preventive or a therapeutic measure should be given in an appropriate time. So by doing all these things, definitely we can compress the morbidity period.
Thank you, Dr. Revati. And so basically, we apply the 10-point program in these patients. We first advise them about lifestyle management. We take care of their mental health also simultaneously. We teach them about the smoking and alcohol and their abuse, advise them to lose weight, and whenever needed, we must go for interventional procedures like any bone health procedures like knee replacement, hip replacement, cataract. So everything should be explained to our patient. And when we avoid this 10-point concept in our practice, we are going to give them a holistic lifestyle. Dr. Anju?
Yeah, so my next, before going to the next question, I would like to touch a very, very important aspect, which is happening all across the world. We know that there are about 2.1 billion of people who are suffering with obesity worldwide. And when we look into it, that we see that there is overall a rise in overweight as well as obesity from 28.8 to 36.9, and vis-a-vis 29.8 to 38%, which is quite high. And when we look at the world chart, we see that India is rocketing very high in the level, because it is coming as third largest country in the world suffering from obesity, not only in the urban population but also rural population. And when we look at this figure, we see that there are many countries which are having a lot of prevalence of obesity, like Rajasthan, Uttar Pradesh, Kerala, etc. You can see in this map of India, and which when I was going through it, it really scares you off, that how we are going towards a we are sitting over a volcano. So this question is to Dr. Pankuri. Dr. Pankuri, I hope you are there.
Yes,
Lady who is 46 years old and she's asymptomatic obese, who has never visited a doctor after her delivery 90 years earlier, visits you for weight loss. How will you assess and assist her?
I think it's a very common scenario in our OPDs, because after some time they think that obesity हमको बस reduce करनी है. But I think आप तीनों के जो आप लोगों ने plot खेला, उससे काफी मेरे questions का answer you have given. So if she has come, it's a great time to assess, as she is in a perimenopausal age. So we will screen her, first take a detailed history about how was the onset, is she suffering from any other symptoms of any associated cardiac disease or leg pains or osteoporosis, headache, anything. And we will make her first BMI, take her BMI, weight, height, waist circumference, and classify her that is she coming in the risk of, she is coming in which type of risk, great risk, greater risk. I would like to, you already sir said that Framingham score, that helps much better in these patients, so that they also know that where we are in the scoring, and then how we have to reduce that obesity. So I will start with a good history, family history, assess for her risk factors for the menopause, and then we'll go ahead.
So basically, Dr. Pankuri, you would like to say that any patient who comes to you, you must always take her waist circumference and her waist to hip ratio also, because it is the androgenic obesity which is the risk factor for many of the recent metabolic disorders, and we will take care of that. And after that, we have to, what would you explain to her, that why does she need to reduce her obesity?
We have to tell her all the risk factors what her obesity carries along with. Obesity is just not a physical appearance. It comes along with lots of fat and lots of issues also. So she is at high risk of diabetes, high risk of heart disease, high risk of bony problems, high risk of hypertension. Even neurological disorders are going to increase with all these. So she has to be serious about her obesity and work on it. The earlier, the better.
It is very, very important thing nowadays. She not only suffers from malignancies, there is a very, very high risk of sleep apnea, which further leads to many, many problems. So these patients have to be told that you are at risk of so many problems. Especially, we have to tell them about the shape of the body, pear shape versus apple shape. And we all know that apple shape poses a greater risk for cardiac disease and hyperglycemia. So they have to be explained everything. And once you explain them, I'm sure they will be able to understand and look into it. And when, this slide shows very beautifully that 73% of the women need to lose weight because they're at a very high risk, and they need to lose about 11 kgs, most of them, and a lot of women require it. And what are the different options given? Can you please enumerate? I have just shown a pie pyramid of these problems,
Always the first thing is, the most important thing is lifestyle modification. Without starting and without ongoing this, nothing will work for any patient, I think.
Ask her to join the exercise.
Yeah, that is the most easiest thing to say and most difficult thing to do.
So basically what we do is that we have to just gauge the severity of obesities as well as gauge the associated comorbidities. So once we make a correlation between the two, and it is on the basis of this that we decide what therapy we would like to advise. Of course, when the BMI is between 25 to 30, we rely on lifestyle modifications like diet and exercise, which will be has been discussed in detail also by Dr. Vijay Pathak. Then after between BMI of 30 to 40, if there are comorbidities, then at 27.5 with comorbidities, we will start pharmacotherapy. And if it is without comorbidities, pharmacotherapy will be started after 30. Similarly, when BMI is more than 40, we have to advise her surgery because the complication rate would be higher. Or if the BMI is more than 37.5 with comorbidities, surgery is advisable.
Many patients are now asking for liposuctions and all, many ads on Facebook that drink this tea and you will lose weight in 15 kgs. We have to listen to them and gauge them that what are the effects and side effects of all these fast weight loss things. People are very attracted towards that. But main things will go with lifestyle modifications as far I follow.
Right. So very beautifully seen in this, that, eat right, do exercise, and then third is the medications. And 80% of the cases, there is reduction with diet and exercise if it is done properly. And then only medications are required in many less patients.
In peri and postmenopausal women, it is not the increased intake of calories, spending the calories, which is more important, that we have to advise them.
So what is the exercise prescription you will tell, Dr. Pankudi?
And for doctors, I will tell them to join your Sunday morning session of Dancing Blues and be happy.
No, why doctors? Everybody is allowed.
That's what I said, exercise.
Yes, ma'am.
Yeah.
Exercise, I will allow start with aerobic exercise, weight bearing exercise. She should start slowly because it's not easy that first day she do 1 hour, then for a week she is suffering from body aches. So she should start slowly, make some motivation in front of her, put chart or weight or whatever, and then grow accordingly. I will tell her to start with light walking, increase the speed. She can do mild as per her weight and her circumstances allow. Breathing exercise, the pranayams, lom vilom, and everything is very good. As rightly written in this, she should increase it daily and moderately increase the exercise.
And many times they how long to do it. So basically, ask how long to do it, and they stop short after some time. That is again we have to counsel them.
Yeah, and secondly, you have to tell them that it has to be a mix of exercise, that it should be a mix of aerobic, muscle strengthening, breathing, and balance everything. And 30 minutes of moderate intensity physical activity for 5 days a week, then muscle strengthening 2 days a week, 30 minutes for fitness, and reduced risk of chronic will lead to reduced risk of chronic diseases, 60 minutes a day for prevention of weight gain, and 60 to 90 for weight reduction. So this is very important, and this we should all keep in mind. What about diet? This is also, like you just said, the brisk walking and low impact aerobics. So yoga, etc. It has to be a combination of everything. Now, so we have to tell them that stop being lazy. It is only 1 hour a day which you have to give to your own health, so that you can maintain a healthy lifestyle, which will help you to look after your family very well. And of course, that that will help in her, a proper counseling will definitely help her. What
Start
about
with two people, 2 or 3 people. If do any group, then one if goes down motivation, the other will boost up, and it really works. 2 or 3 people if you do together.
So what about the diet?
Diet, it should be high in fiber, vitamins, antioxidants, all kinds of tomatoes, lemons, oranges. They should take. If since we are talking about menopausal, we should tell them to eat dry fruits in the form of almonds, anjeer. We should increase the milk intake. Soya bean is also a very healthy thing. Vegan diet, as it was highlighted in the starting of the session, if they can follow, it is a good thing to do. All kinds of fruit, different kinds of fruit, different types of vegetables, they should take in plenty.
And
so good proportion of
juice.
Sunlight exposure too.
Fruits not as a juice, only as raw fruit again, because only then they can get a good fiber.
Yes, ma'am.
Juices
I don't prefer too much.
As I have shown that their plate should be colorful with all the colorful things in the vegetables, with fruits, nuts. If you are non-vegetarian, you can have fish and eggs, of course, milk, and avoid the fast foods. You just saw that the fast food plate went down and the healthy things came up, which will definitely do not only in the weight reduction, but it will also reduce the carcinoma of colon. So prevention strategies and control of weight and normalization of BMI will lead to reduction in cancers by as much as 26%. So not only at the metabolic disorders, it will lead to reduction in cancers also. Over to you, Shubha.
Yeah. Dr. Revati, what all risk assessment should be done when a woman enters her midlife? What all risk assessment do you suggest?
See, we have to assess the risk for osteoporosis, cardiovascular risk, and also breast cancer, uterine cancer, cancer cervix, and of course, Alzheimer's disease. There is a possibility of DVT also, that risk also if there is a history. We have to look into the history, very important for DVT. And all, of course, all malignancies, breast, endometrial, and ovarian cancer, all these things, we have to identify the risk factors right from the history as well as examination.
So basically, we will have a holistic checkup of the patient. I now asked Madam Shobna Mohandas. Madam, we have just heard that cardiovascular diseases are the leading cause of death in India. Around 24% of all deaths are attributable to cardiovascular diseases. And this brings about in its wake morbidity, mortality, as well as financial burden on the society. So, Madam, how do you suggest that we should look forward and prevent? So what are the risk factors that we should look forward in order to prevent the cardiovascular diseases in our patients?
Yeah,
Shobna, ma'am?
Yeah, yes. See, in Framingham, 25 years, 30 years back, they assessed the risk factors and they've given us it on a platter. So avoidance of trans fatty foods, eating frequently boiled oil, avoiding vanaspatis, including exercise, diet, and all has been oversaid. What is true for diabetes is true for heart disease also. Plus regular checkup of your cholesterol levels. That's about all that I can add. Otherwise, it will be just too much of repetition. This has all been covered all day today.
So all the 4 metabolic factors that are responsible for cardiovascular diseases like diabetes, obesity, hypertension, and metabolic syndrome should be looked forward. Then we should take a family history and try to control all these factors. We would be able to decrease the incidence of cardiovascular diseases. But the only need is that we should be on a lookout for these. If we are not on a lookout, we will miss, and then this is where we need to understand these. Framingham risk score, Madam, is
Framingham.
Framingham risk score, madam has already said that we will, and Dr. Vijay has also explained that we, according to this, we will classify them into mild, moderate, severe, or low risk patients. Anju, Dr. Anju? Dr. Anju, you're mute. Dr. Anju?
Yeah,
Dr.
sorry.
Anju, you're mute.
Yeah, I'm unmuted. So this case is for Dr. Seema, a 48-year-old woman. She came for health checkup. She's asymptomatic except for hot flashes since a couple of months. She's hypothyroid on thyroxine since 12 years. Her sister had rib fractures, and at the age of 54, her BMI is 18. So what will you do in this case, Dr. Seema?
As you have written, what is her main risk? So for me, and classically, if we take in account her history and presentation, we find that she is having hypothyroidism and taking thyroxine, as well as she has a history of hip fracture. So the main risk for this patient is for osteoporosis, and the screening for osteoporosis should be done in this patient. She is a very good candidate for that. Although she is asymptomatic for other things, but she is having hot flashes. So if she turns out to be osteopenic or osteoporotic, then she becomes the best candidate for menopausal hormone therapy also.
So we did a BMD report, Dr. Seema, and this is a BMD report.
Yeah, T score -2. So she comes in the category of osteopenia because for the purpose of description, we have divided these T scores according to WHO classification. Rather, nowadays, we have the classification of osteoporosis on that terms only. So she has osteopenic, she's an osteopenic patient. So as we are talking since beginning about lifestyle modifications, dietary changes, all these we have to prescribe her. She has to be counseled regarding proper intake of calcium, vitamin D, sun exposure, all these things, those are going to be repeated, as well as she should be on follow-up, and she can be also a candidate of MHT according to her.
Could you please explain about BMD and the Dr. Seema? Could you please explain about this BMD scores a little, more for people who are attending?
Yeah, the T score, they are in terms of standard deviations. The normal BMD is plus and minus 1 standard deviation from the normal, and low BMD we consider as -1 to -2.5, below means -1 to -2.5 standard deviation, and osteoporosis is below -2.5. And if it is accompanied with a fracture, then we call it severe osteoporosis. And there is another score that is known as Z score. So these two scores are important. What happens in T score? T score is for general population, but Z score, that is for age-matched person. So in routine testing, we take care of T score.
Could you please tell something about MHT and bone?
Yeah, as we know, the pathophysiology of osteoporosis starts from the an estrogen depletion state, and because of that, there is a development of osteoporosis. Osteoblastic activity is reduced more than that. The osteoclastic activity is more. So if we use MHT in these cases, in early menopausal cases, either within the 10 years of having menopause or before she is 60 years of age, then it is really going to be a beneficial type of thing. And as we have discussed already, nowadays the lipid-friendly hormone therapy is available, which is having less effect on the derangement of the lipid profile in form of dydrogesterone, or in patients who have already undergone hysterectomy. I suppose this patient is having the intact uterus. So for this patient, I would like to add the dydrogesterone.
She was already suffering with hot flashes.
Yeah, she is suffering from hot flushes also. So for the hot flushes also, NXT is the best treatment, and particularly in this age group. So she is the best candidate to have this therapy.
Dr. Seema, would you advise MHT in all patients with osteopenia or osteoporosis?
No, not at a blanket type of thing. We have to always tailor the therapy. We have to see the patient profile. Suppose a patient is coming to me at the age of 75 years and she has not taken any hormone therapy for long period and like since menopause, then really we have to go for the other things, because at this age she needs a osteoblastic thing, anabolic thing more. So in those cases, if severe osteoporosis is there, we would like to use teriparatide and denosumab to have a better bone mass.
So basically, we see whether the patient is osteopenic or osteoporotic. In all osteoporotic patients, we will give pharmacotherapy, whereas in osteopenic patients, those with one major or two minor risk factors, we do therapeutic intervention. And depending on whether she has menopausal symptoms or she does not have menopausal symptoms, the first line of treatment is either menopausal hormone therapy or bisphosphonates, and anabolic drugs are usually added when there is severe osteoporosis and when the BMD score is less than -3 and the risk of fracture on FRAX score is more than 30% and the hip fracture is more than 3%, then we'll be adding anabolic drugs. Otherwise, we start with bisphosphonates or denosumab, which are anti-resorptive drugs.
What else? What else should I apart from this? You have already given her, hormone therapy as and when needed and other drugs, as Dr. Shubha said. What else you will give her?
No, before hormone therapy and before every other drug, I will start with the LSM, lifestyle modification, then calcium, then vitamin D. All these things first should be given, and then switch on to MHT and pharmacotherapy.
Yes.
Yeah, and
absolutely. So calcium, vitamin D, exercise, quit smoking, drink alcohol in moderation, cut back on salt and caffeine, bisphosphonate, teriparatide, and then SERMs as and when required. So
this is the crux.
Yeah, this is the crux. So this question is to Dr. Sweety Soni. Shubha, can you take over?
Yeah. So aging can be fun if you lay back and enjoy it. That is what we have, what was said by Clint Eastwood. Dr. Sweety, ma'am, can you change the slide? Dr. Anju, could you please change the slide? So many of women say that beauty of a woman with passing years grows, definitely with aesthetics surgery. It was Sri Devi who said that women over 40 should look after them and do what makes them desirable. So if there is a female who comes to you and who is desirous of cosmetic surgery, what all advice would you give us? What are the various measures that are available for cosmetic surgery for this female? Would you advise or would you inhibit?
Aesthetic and cosmetic surgery is coming up in a big way, especially in the last 1 decade. And in hands of good surgeon, the results are really good with minimum or no complication rate. So if after thorough and appropriate counseling, if the woman still wishes to go ahead, I think we should not stop her from, looking beautiful or looking young or desirable. I mean, if that is what she wishes for, I think we should go by it. And there are many options that are available, like, right from the brow lift, facelift, chin lift, tummy tucks, augmentation or reduction mammoplasties, lot of dermal fillers using Botox under the skin to get rid of wrinkles, lines, and something that has come really latest as injecting platelet-rich plasma or stem cell therapy is also coming up in a big way. So yes, the woman has a lot of options, and as I said, if she's willing to, we are no one to stop her. There are options available.
So Anju Didi, your slide share has stopped. Dr. Anju?
And as Dr. Sweetie is talking about platelet-rich plasma and stem cell, it has
no. It's so
It's
what?
yeah, you can see the slides now, ma'am.
Yeah. Yeah, so Dr. Sweetie, as you've already said, there are various procedures like brow lift, face lift, neck lift, blepharoplasty, rhinoplasty, Botox filters, lip enhancers, and mammoplasty. So we will always look towards the desire of the patient, explain the pros and cons of all the surgeries, and if she is willing to go through it, we will never dissuade her, but encourage her that she has all rights to do what she feels happy in. Anju, Dr. Anju, next slide, please.
So this question is to Dr. Shobna Mohandas. Mrs. P has become lonely after her only son got married and went abroad. She has a trouble of falling asleep and feels lost. How can we help her? Dr. Shobna, are you there?
Yeah, I am there.
Yeah, please.
She is her only son got married and went abroad. That she should be able to be. Maybe we can counsel her a little bit and she may get better. But if she has got trouble in falling asleep consistently for more than 15 days, you ask if she's got trouble in falling asleep initially, or she's falling asleep but getting up at 4 o'clock waiting for others to get up. If it is falling asleep, that is a difficulty. It could be anxiety, can be treated by clonazepam or other anxiolytic drugs. Not the older ones like alprazolam. Nowadays, clonazepam has replaced it. But if it is you can sleep, but getting up at 4 o'clock in the morning is a problem. It is because of the depression, and there you have to give antidepressants. Yes, there can be a lot of things like this emptiness syndrome. I said counseling can be done initially, but sometimes it works, sometimes it doesn't work. Quite often it does work, but then initially to give them a little fill up, you may have to give drugs a little bit. That is there. This is what I do in my practice.
Absolutely, because this is one of the very common condition nowadays. Because husbands are busy in their own work, and she feels lonely. So the counseling sometimes does not help them, and we need to give them enjoy your personal counseling, of course, about it, enjoying personal.
You have to differentiate between anxiety and depression. If it is falling asleep, which is a problem, it's anxiety. If it is getting up early, it is depression, and the drug treatment is different for both.
Absolutely. So symptoms to look for are irritability, fatigue, lack of interest, appetite, mood swing, and can be treated without medication if person realizes the conditions early. But in cases it is later, we need to give medical treatment. So this is to Dr. Revati again. Mrs. S, she is 53 years, has no interest in having sex as it is very uncomfortable. What are the possible reasons? Dr. Revati?
Maybe because she has got, because of the estrogen deficiency, she must have had vaginal dryness and such problems. So we have to ask what exactly is the thing. And then you have to give her treatment for that, like vaginal lubrication or estrogen, local estrogen cream. And partner relationship also we have to discuss that. There may be a lesser sexual desire in her. Yes, all these things because of the LSD. Should be having.
Because of loss of estrogen and testosterone, she has got hypoactive sexual desire, and she could be, less sensitive to, and there could be blood, of course, drop in blood supply of the vagina, which could decrease the lubrication. So basically, she is suffering from, genitourinary syndrome in this condition. She may have other contributory factors also, like bladder control problem, sleep disturbances, depression, anxiety, and stress, and maybe some medications can also lead to this problem. So we need to take a detailed history and manage her this problem. And we can help with, as Dr. Revti has already said, that we can help with lubricants, moisturizers. We can give her a low dose vaginal creams and change medication which cause dryness.
Oxytocin also can be tried, or sildenafil can be tried.
Yeah, even sometimes this antihistamines can give to vaginal dryness, and so that they have to be they should get enough sleep, avoid alcohol, lose weight, and there are some drugs like osmifene which makes the vaginal tissue thicker and less fragile. And of course, sildenafil we all know is very helpful. Now latest coming up, and sexual practice wherein there is more foreplay and change of position which will make her comfortable. And of course, clitorotherapy has been also approved by FDA. Now, age is inevitable and aging is not. Dr. Shubha, over to you. Dr. Shubha, are you there?
Yeah. This is a 43 years female, a busy CEO in a multinational company. She never thought of about a pregnancy, and now she feels that she wants to have a child. How will you go about this? And what are the different problems that we encounter? Dr. Sweetie Goni, would you enlighten us about how we will manage this patient?
Yes, ma'am. Ma'am, this is something that all of us are coming very regularly in our day-to-day practice, where women are not getting pregnant at an earlier age, but come at more than 40 years of age, considering that they want to have a baby. First and foremost thing would be that we have to consider some factors and counsel the couple regarding what can be the issues that can be associated with getting pregnant at such an elderly age. One of them is the declining fertility as the age increases. Secondly, as the age increases, the oocyte quality deteriorates, making the woman difficult in getting pregnant, as well as increasing the risk of aneuploidy or chromosomal aberrations, causing higher risk of miscarriage. At this age, women are also prone to have other medical comorbidities like hypertension, diabetes, obesity, and things like that. So once we have counseled, we go ahead with the workup of the women that will involve the basic infertility workup, serum AMH to determine what is her ovarian reserve, and then obviously optimizing the general health before we guide her as to what are the treatment options available for getting pregnant.
Yeah, you have already typed it. What are the treatment options available for her?
Okay. Ma'am, okay, so you've got the list for me. Natural conception is not something that I would recommend this woman. IVF ICSI has got a better chance. So if all her parameters are good, then we could suggest IVF ICSI. If the couple, sometimes the couple may not be ready to go ahead with in vitro fertilization. In that case, IUI can be an option, but only for 1 or 2 cycles. If she doesn't conceive in those 2 cycles, then I think we have to go ahead with IVF. Now, even with IVF, the results may not be very good because beyond 35 years of age, the ovum quality deteriorates. So egg donor will give her the best result.
I just would like to share one of my patient, 50-year-old doctor. She came like this and she opted for ART procedure. But unfortunately, 50 plus, they will not accept it, seems. Yes. But she said, I will reduce my age and then put it as 48 and then come for it. Unfortunately, it was not possible because they asked for Aadhaar card. So she couldn't do it.
In these cases, can she go for surrogacy?
Yes.
Ma'am,
but my patients, even 50 plus, they allowed this and they gave home donation and they got a child. Maybe Madurai is different, Trishur is different.
Yeah, so is surrogacy an option in these cases which you are discussing?
Ma'am, surrogacy is like, I mean, there is a partial surrogacy and complete surrogacy. So one is where you have the donor egg and then implant the embryo in some other woman's womb. Now, if this woman of ours, if she is fine and she can bear the child, then we could do a IVF using the donor egg, and a surrogate may not be actually required.
So depends on the presence or absence of comorbidities that we will decide that we want to go for surrogacy, or we would like to let her conceive with either ovum donation or anything else.
So you have already elaborated many things that, you know, we can give her CoQ10 and the supplementation. Of course, the researches are there that they may not increase anything, but people are giving left, right, and center. Then catenin is also been said to improve the ovulation, but then the studies are again not very, you know, they are still under evaluation, and of course, the cumulative rates. And what about role of DHA?
Ma'am, again, there are some studies which have suggested that DHA improves the quantity of the follicle, the quality of the follicle, it increases the conception rate, but not all studies actually support this role of DHA. And I think we still need more of randomized control trials to actually come to a conclusion.
And what about some few procedures which have come recently, PRP and all those things?
Yes, ma'am. That's exactly what I was talking about in my previous question also, where, you know, PRP and stem cells, they've come up in a big way for aesthetic, cosmetic purposes also, where you can use, PRP is basically platelet-rich plasma. So you take the woman's blood, concentrate it so that the platelet levels, like, you know, are about 5 to 7 times the normal platelet level. Now you can use this PRP either like Botox, injecting under the skin to get rid of wrinkles and fine lines. There have been some trials where they have injected PRP in the ovary, and then they have said that after this procedure, there has been an increase in the AMH, there has been a decrease in the FSH levels, and you know, more of the follicles were seen, more oocytes were obtained when they did induction for IVF. So again, something which is still, you know, in a very neonatal, infantile stage, and more studies need to be done. But a lot of work is going on all over the world.
Here, I would like to share that we are also conducting the similar study on PRP at our centers. We have injected PRP in the ovaries through transvaginal route. And initial results we have done till now in 10 cases, and they are very encouraging. So let us see what comes with this study.
Very well said, Dr. Seema. It's still in infantile stage. I have seen a lot of people doing it, but you know, we have to keep our fingers crossed till we come to a conclusion, and of course the proper guidelines.
In premature ovarian insufficiency, also many people are using PRP and stem cells because those who do not want an ovum donation.
In a recent conference of JOGS, I also heard Dr. Niket. He presented a very good presentation that how he injects this PRP and stem cells in the ovaries in the women who have lack of ovarian functions, either maybe because of premature ovarian failure or any other cause.
Dr. Madhulika, a lot of people
very
are
good
doing it, but
results.
still there are no proper guidelines at the moment, even internationally also.
Yes, yes.
So we leave it here. Before we close the panel and summarize it, I would like every panelist to give a, you know, a little of their message from their side. Dr. Shobna, your message first.
Yeah, I think there are so many options besides just waiting for the son's letters or waiting for surrogacy and begging for adoption. So right from there, from emotional to physical to aesthetics, the world is open, wide open for a menopausal woman. राम राम करके बैठना है तो बैठो, या तो तुमको 20 साल का लड़की का जैसा जीना है तो जियो. आपकी बात.
Dr. Seema?
Yeah, I will also endorse my president definitely. And aging is really a topic of today, because we can really compress the morbidity. As the theme of today we have chose, we can compress the morbidity, and we should work towards it so that we can really have a good quality of life ultimately, which we need.
Can I add something to
this?
this?
Starts from
Dr.
lifestyle
Seema's
modifications, which
Madhulika,
have talked.
let the panelists speak first. What, Dr. Revati?
Yeah, we have to make women understand that it's menopause friendly. They should never get afraid of the consequences or something like that. Okay, that is one thing very, very important. And as we have rightly discussed now, aging gracefully. The same way they have to accept the aging in a pleasant way. And remember that we should never regret for aging, because it is denied to many. So we should enjoy aging. That is what we have to tell them. Thank you.
Yes, ma'am. I would actually like to reiterate what Dr. Reti has said. One thing is spreading awareness, giving confidence to our women that this is something which comes naturally, and it is important that we become physically, mentally active and accept it very gracefully and happily.
Dr. Pankhuri? Dr. Pankhuri, are you there? Dr. Pankhuri?
And one word about the emptiness syndrome, we have to prepare them in the premenopausal age itself, how to engage themselves in various ways, so that they will never have to face the area of emptiness syndrome. That also we have to guide them.
Yeah, actually, very well said, because we have to tell them that the hobbies you never took up earlier.
Yes, menopause, yes.
You have to take those hobbies and make yourself happy. That's very important.
All these things.
So growing old is natural, but feeling old is not. And we all know that process of aging or senescence, there is decline in maximal function of vital organs, decline in reserve of power well before clinical visibility of limitations, and frail elderly subject to increasing concern is today's utmost need, and individuals without disease, and we should always catch them at the right time. And as this shows that we should make a cone of the problem where patient stays has all the reserve with them, like kidney reserve and heart reserve, and with the age the cylinder remains narrow for the normal homeostasis. And you can see in this graph that successful aging is where the morbidity occurs at a very, very late age as compared to early in the journey, where you are physically active and mentally active and strong with social engagement, proper meaning of your life, purpose and meaning in your life, and of course environment that supports a lifestyle. And as said by many people, that you know that you are at perfect age, each year is special, precious for you, shall only live it once, be comfortable with growing older. Age is an issue of mind over matter. If you don't mind, it doesn't matter. I believe the second half of one's life is meant to be better than the first half, and the first half is finding out how you do it, and second half is enjoying it. Getting old is like climbing a mountain. You get little out of this thing. And as said by Ernest Winder, that the function of medicine is that people die young as late as possible. And thank you very much. And I'll stop sharing and have views from all the people in the who are there.
Birthday baby Shubha, please show your face. I would like to take a picture. Thank you. Smile, please. Cheese.
Thank you so much.
Thank you. I'll send it. I'll share.
Dr. Sunila, you would like to say something?
Oh, I'm really happy. I enjoyed the whole session, and everyone was so encouraging and giving the quality of life to the women in their second adulthood, and that's all. And I would just end the end say, "Zindagi na milegi dobara." Isliye we must let the people enjoy, live, love, and laugh. Nothing more.
Absolutely. Dr. Shobna?
मैंने बोल दिया ना, enjoy. Let everybody be like
But
a
thank you so
gynecologist.
much. It was really wonderful session. Very nice. Well done, JMS. Well done in center team. Very nice and good initiative. Loved it.
Center
Thank
और
you.
जयपुर सब so एक ही बन गया अभी. Vice President, President
बात
दोनों
तो
उधर
सही है.
से
That is
दोनों
very
मैडम आप
जयपुर
लोग
के.
हमारे पास आ जाओ. You all come to us.
Yeah, because majority of center is at Jaipur. No,
Nice.
I'm
Very nice. We enjoyed
very
it.
nice to see you all in the pink city. Thank you so much, Dr. Revti, Dr. Sweet. The other one was
Dr. Vandana Narula also.
yeah.
Dr. Ritu Khanna, all of them. Thank you very
Yeah,
much.
yeah. I can see
for
many
being there.
names. So many are here. That's very encouraging for us. Thank you so much. Bye.
I just want to say a few
Thank you,
lines.
ma'am.
उम्र का
Bye,
बढ़ना तो
Vandana.
दस्तूरे जहाँ है, उम्र का बढ़ना तो दस्तूरे जहाँ है, अगर महसूस ना करो तो उम्र बढ़ती कहाँ.
बिल्कुल नंबर है सिर्फ.
बढ़ेगा तो क्या हुआ?
हाँ,
So
बूढ़े का
what
है.
if it goes up?
Age is just a number.
Yeah.
And madam, we are all experiencing it, that if we are happy, it doesn't make what ailments, what problems you have. And this is what we have to explain to our patients. If we can do that, our purpose is solved.
सुनीला
So
दीदी
we have to be
कैसा
their
लगा?
role models, I think.
सुनीला दीदी हमारा रोल प्ले कैसा लगा?
बहुत अच्छा. Very nice. हर बार नया करते हो तुम लोग. Very nice.
Thank you.
Thank you.
अब कभी पेशेंट बन जाते हैं, कभी डॉक्टर बन जाते हैं.
बस the timing मेरा consulting hours में था, so I couldn't
करना
enjoy
है,
all of it.
करना है, करना
I
है.
know. नहीं, अच्छा. बहुत सारे वीडियोस इकट्ठे हो जाएंगे. Then you can put on our website also, and so
this is what
everyone
we
can
will
use that.
You wanted some other time? What time you wanted?
My webinars are always scheduled for 6 to 8, but I don't know how this timing got changed, and I couldn't really attend each and every
So
part.
bye everyone. I need to go. Bye.
Ma'am, so shall I close the session?
Yes, yes.
Thank you everyone for joining.
Very nice. Anju and Shubha, very nicely conducted panel. Thank you very much. Thank you. Bye. Dr. Shobana.